A very good morning to all the doctors who joined us here today. This educational initiative is supported by Abbott. So, welcome to the lecture on recent advances in the treatment of liver diseases. This is this is a certificate course that will be providing an RCP credit on successful completion of the Q&As that have been provided on the next tab. So make sure to answer the assessment after the session to receive your RCP credits. So today's session has two very dignitary speakers with us. So I'd like to introduce both of them. So taking my part, I'll introduce first Dr. Philip Abraham. Dr. Philip Abraham will be covering the HBV, HCV related chronic liver diseases. Dr. Philip Abraham is a retired professor and head Department of Gastroenterology, KEM Hospital, the past president of Indian Society of Gastroenterology and Indian Motility and Functional Diseases. He is also a recipient of Lifetime Achievement Award from Indian Society of Gastroenterology, the past editor for Indian Journal of Gastroenterology, and has also delivered several orations and an author in nearly 100 original publications in index journals. So this is just a declaration from the speaker where the speakers declare that there is no conflict of interest with the presented material in the presentation. So next, I'd like to introduce Professor Gauradas Chaudhary. Professor Gauradas Chaudhary will be talking about the fatty liver diseases, diagnosis, monitoring, and treatment. So Professor Gauradas Chaudhary is the director and HOD of Department of Gastroenterology and Hepatobiliary Sciences, Fortis Memorial Research Institute, Gurgaon. Past president for Indian Society of Gastroenterology, former professor and head, Department of Gastroenterology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. First to start endoscopic ultrasound and also extracorporeal shockwave biliary lithotripsy in India. Played a leadership role in developing liver and digestive healthcare in the country. Has over 200 scientific publications as well as several orations and awards to his credit. Over 30 years in the profession with vast experience and expertise in diagnosis and management of a wide range of liver and GI diseases. A skilled endoscopist as well. Doctor is also the Executive Director for Department of Gastroenterology and Hepatobiliary Sciences, Fortis Memorial Research Institute, Sector 44, Gurgaon, Haryana, and also honorary professor for Vivekananda Institute of Medical Sciences, Lucknow, and founder of the Hope Initiative. So I welcome both of you speakers, and also Doctor has to declare that there is no conflict of interest with the presented material in the presentation. So I'd like to welcome both of you speakers for taking time out for this valuable and educational session we are having on a Sunday morning. Now I'd like to request Dr. Philip Abraham to please go ahead and start off with the first session.
Thank you, Hitesh. Those very kind words of introduction, much of them undeserved. I will now take up the mandate that you have given me. Although the title of the topic given was Hepatitis B and C Chronic Liver Diseases, I thought I would cover the gamut of hepatitis B and C as seen in common clinical practice. Of course, I stand between you and Professor Gauradas Chaudhary, an old friend of mine, who will be speaking on fatty liver diseases. So, since the mandate is for Hep B and Hep C chronic liver disease, let me just
Yes, sir.
begin by
Sorry to interrupt.
introducing. Yeah.
The screen has not been shared yet, sir.
Oh, I'm so sorry.
You just need to click on share
Uh,
screens.
can you see it now?
Yes, I have your screen here. Yeah. Just need to go to the
You have it
presentation
now?
and slideshow mode.
I'll do that. I'll do that.
Yes, sir. The slideshow, please. Yes, sir. Thank
Yes.
you. You can go ahead.
Am I okay now? Thank you so much. So, since we're mainly bound to talk on chronic liver disease, let me just introduce the definition of this condition of CLD. Now, this definition has been made mainly in the context of Hep B and Hep C, but broadly we've applied it to definitions or chronic liver definitions for the other etiologies as well. But what's important here is for Hep B and Hep C, the reason why we have a 6-month cutoff is because the histological changes in chronic liver disease may mimic those of acute liver disease, which is why we need to have a time cutoff before we call this chronic liver disease. Now, this may not be applicable to all causes of CLD, but in Hep C and Hep D, Hep C and Hep B, yes. So, by definition, we need to have documented inflammation, necrosis, or fibrosis. We don't need to have all three in the liver for at least 3 months. And the way to diagnose that could be clinical, laboratory, or histology. So, for example, if a person comes to us with decompensated chronic liver disease or decompensated cirrhosis, we don't have to wait for the 6 months. You know that this patient already had cirrhosis for a long time. So, clinically, you may make a diagnosis of cirrhosis, although it's almost impossible to make a diagnosis of chronic hepatitis only clinically. On labs, if you have evidence of low albumin and raised transaminases, and this has been documented for 6 months, you could call it chronic liver disease. And of course, if you have extensive fibrosis or documented fibrosis on histology, you could call it chronic liver disease. So what you realize here is that the term CLD or chronic liver disease is not synonymous with cirrhosis, but includes cirrhosis and has a potential to progress to end-stage liver disease, which will finally need transplantation. So for hepatitis B and C, the definition of CLD is documented chronic changes for 6 months. At any given time, you may not have all the changes. For example, you do a biopsy and you find that this patient has extensive fibrosis. He may have normal transaminases. So you don't need to have everything before you make a documented diagnosis. So like I said, all features may not be present at any given time. So to reiterate, CLD includes cirrhosis, but is not synonymous with cirrhosis. We have a stage of chronic hepatitis preceding that, where you could have inflammation and necrosis and early stages of fibrosis. And fibrosis can be categorized as stage 1 to stage 4. Now let's come down to hepatitis B. We are most of us familiar with the epidemiology of this infection because there's so much talked about it all over the world. But this is a map that I've borrowed from the Lancet published 5 years ago. If you notice, much of the high risk areas are in sub-Saharan Africa, as well as in Central Asia and the Far East. So Vietnam, for example, and the nearby countries, and some parts of the Philippines and Indonesia are also taken as high areas of high prevalence. India at one time was categorized as intermediate prevalence. At a time when we had only low, intermediate, and high, India was categorized as intermediate, which was 2 to 7% of the population. But now we know from large community studies that our prevalence rate is probably less than 2%. So we've been reclassified as low intermediate or low prevalence country. Among the countries, among others who share this feature with us are the Western countries and the so-called industrialized or first world countries. So India is among a low prevalence country, but given the large share of our population in the global population, although we have only 2% of our prevalence of our population being infected, in sheer numbers, we are 10% of global carriers. So about 30 to 40 million Indians are hepatitis B carriers. Now, everything that we know about hepatitis B is from the patients who report to hospitals or the patients who have been accessed from the community by doctors. My point always is a philosophical one. What do we know about individuals who have never been seen by a doctor or never visited a doctor? Do we know if there are huge numbers outside who have the infection but never knew about it and never suffered from it? But everything that we know is from those whom we have accessed as patients. In India or in high-risk countries, the transmission of the infection is generally vertical, that is, mother to child. In India, it occurs in early life, but it is not predominantly a vertical transmission. It's not a mother to child transmission. Most of our infections occur in the first 5 years of life. And unfortunately, although that features as a horizontal, not a vertical transmission, we don't know how it really happens. Is it close contact? Is it crowding? Is it shared utensils and other things? We don't know. But what we do know, with elegant data coming from the NIV in Pune, is that a majority of Indian infection occurs horizontally, but in the early years of life. And this is important for us when we talk about management later. Let's come to the markers that we would target when we're making a diagnosis of hepatitis B. And here I want you to pay attention to a few of those. A Positive hepatitis B surface antigen is the first test that we would do to diagnose Hep B. And for acute hepatitis B or for Hep B in general, a positive HBsAg is for practical purposes the only test we need. But there are situations where an acute infection or even a chronic infection may have a negative HBsAg where only the anti-HBC is positive. So you'd notice that except in those who are immune, all the others would have an anti-HBC positive. So the question that will cross your mind is, in that case, why don't we use anti-HBC as a screening test? The answer to that is, in a screening population study, if we have anti-HBC positive, we don't know whether these people have active infection or have the antibody. So when it comes, for example, to a vaccination program, you may want to know who is antigen positive, who is antibody positive, except that in the community, you would rather give vaccination without testing because it is safe. So, to summarize, HBsAg is the most commonly used screening test for HBV infection because it is positive in most cases. In the isolated case where the surface antigen negative and we have what we call an isolated core, an anti-HBC is still positive. The other place where we use anti-HBC or HBV DNA when the HBsAg is negative is in what we call occult infections. Now, we truly don't know the implication of this word occult infection, meaning where the surface antigen is negative, anti-HBC or HBV DNA is positive. What is the long-term outcome in these individuals? There's increasing data to say that even if the surface antigen is negative, these individuals have the infection and have the potential for further course of the disease. An anti-HBC is specifically tested in people who are due for transplant or for dialysis or for chemotherapy or immune suppressant therapy. Because there, even if the surface antigen is negative, we want to rule out by every means that these people don't have exposure to hepatitis B. So, for example, a person who is going for chemotherapy, for example, malignancy and chemotherapy, even if the surface antigen is negative, we would test an anti-HBC and an HBV DNA to look for what is called occult infections because they have the potential of flare when these individuals go in for immune suppressive therapy. So to summarize everything on this slide, the first test is HBsAg. In specific situations, we would also want to do an anti-HBC and an HBV DNA, particularly when the patient is going in for immune suppressive therapy. But for screening, if we use these two tests and diagnose what is called occult infection, we don't know what to do with them later unless they come to an immune compromised state where we would treat them as infected. So I hope I made that clear. Now let's look at the natural history of hepatitis B. Obviously, the disease starts with acute infection. So that's where it all begins. If you look at the fine print below that, it says that 90% of infected children progress to chronic disease, whereas less than 5% of immune competent adults progress to chronic disease. So an acute infection need not progress to chronic infection. I'll show that in more detail in the next slide. And I want you to remember this when we're going to compare this with hepatitis C. In hepatitis B, an acute infection more likely than not will clear, unlike in hepatitis C, where the chance of progressing to chronic disease is much higher. So let's look at that in a little more detail in this slide. If an individual acquires the exposure when at birth or early childhood, the chances of chronic infection are more than 90%. On the other hand, if the individual acquires this infection or is exposed to this infection as an adult, the chance of chronic disease is just 5%. So the red line is what's the likelihood of chronic infection developing, and that depends on the age at which the infection exposure has occurred. The second line, the yellow line, is the likelihood of symptomatic infection. Till the age of 12 months, an individual who acquires the infection may not have symptoms from that at all. An adult who acquires the infection has a 40% chance that he will have symptomatic infection. In other words, for practical purposes or on a philosophical note, if an individual has to be exposed This would be the right time where there are no symptoms and the chance of chronic infection are low, but that's not something that our clinicians or epidemiologists will ever agree to. The later in life the infection occurs, the chances of chronicity are low, but the chances of symptomatic infection are higher, and the chances of complications of acute infection are also higher. So we don't want the infection in early childhood because the risk of chronicity is high. We don't want the infection in adulthood or older children because the risk of symptomatic infection is high. So both ways, we don't want exposure to hepatitis B. Now, in the 90% of children who progress to chronicity, or the 5% of adults who progress to chronicity, a majority may remain asymptomatic. Now, I want you to remember the word asymptomatic as not synonymous with healthy. These may be inactive and they may not have clinical manifestations most of their lives, but they are not healthy carriers, and I'll come to that later. A majority may remain in this stage, but 5 to 10% of them, or let's look at this earlier, about 30% will progress to chronic liver disease and progress to cirrhosis. This is after they go from acute to chronic. 30% will progress to cirrhosis. And these figures are again important when we compare that with Hep C, because you see that the risk there is much higher. So once chronic infection develops, 30% will progress to cirrhosis. 5 to 10% may progress to liver cancer, given risk for life. And not all of them, remember, will need to go through the stage of cirrhosis. So a chronic infection can progress to liver cancer without going through the stage of cirrhosis. That's important. And this is true for Hep C also. And like we'll say earlier, well, like I'll show in the next slide, inactive carriers also have a risk of going this way. So chronic infection, 30% cirrhosis, 5 to 10% liver cancer. Some of them will be going through, or most of them will be going through a stage of cirrhosis, but some of them may develop liver cancer even without going through a stage of cirrhosis. So what's the cause of disease and chronic infection? We have the first stage of what's called immune tolerance stage, where the virus load is high, obviously, because that's an acute exposure, but the ALT or SGPT is low. That means the body is now tolerating this infection. The virus load is high, the ALT is low. What does this imply for us? That much of the damage occurs when the body starts fighting the infection. So it is the attempt to clear the virus that results in liver damage. As long as there's a stage of tolerance, the SGPT level remains low and there's minimum or no hepatitis. The moment the body starts fighting to try and clear the infection, or what's called the immune clearance stage, the virus load will come down, but the inflammation will be ongoing, and that's a time there is active hepatitis, which by now can be chronic hepatitis. So this is HBeAg positive chronic hepatitis B. If the body wins the battle and the virus comes to a low level, the enzymes will also settle. So this is the stage that we call the inactive carrier stage. Unfortunately, this is not a quiescent stage for life. In some situations, spontaneously, as well as those in whom there is immune compromise, there can be a reactivation of the infection. But here, unlike here where it is E antigen positive, here it is E antigen negative, because the body has managed to clear the E antigen in most cases. So here we have an E antigen negative chronic hepatitis B. So remember that those who are inactive carriers can progress to reactivation, and this stage keeps going back and forth in anywhere from 10 to 30%. So once a hepatitis B patient, you're a hepatitis B patient for life, even if you are an inactive carrier. One more point that I'd like to make here is that in vertical transmission, they have a prolonged period of immune tolerance. In horizontal transmission, that means infection acquired after the age of 20 years, we may not have the stage of immune tolerance. The battle starts immediately and the progression. At this stage, there is a small chance that the individual may clear his surface antigen. The figures quoted are 1% per year, but we don't know who that 1% is, and there is a diminishing return. So spontaneous clearance of the surface antigen, which is taken as cure, happens very rarely, a majority will remain in this state. Now, why do we not call them healthy carriers? Why do we call them inactive or asymptomatic? Because they have no symptoms. The reason is the risk of cirrhosis and hepatocellular carcinoma remains in this group. So, even if they are inactive carriers, there is a risk that they will develop hepatitis or hepatocellular carcinoma. So, like I said, no individual with hepatitis B is cured of the disease even if he has no symptoms. ALT is normal and the virus load is low because there's always a risk of hepatocellular carcinoma, unless in the rare and happy situation where the surface antigen is cleared. So remember that for life, and remember that these patients are patients for life, unfortunately. But the risk of cirrhosis, of course, depends on what kind of disease is present at any given time. So 2 to 6 per 100 person years will develop cirrhosis if they have chronic hepatitis. On the other hand, if they are asymptomatic and have normal ALT, the figures are only zero point 0.5 per 100 years, 100 person years. So 2 to 6 here, zero point 0.5 here. Over 5 years here, over 17 years here. So the risk is much lower in the asymptomatic individuals with normal ALT, but exists. It's not zero, much lower than those who have chronic hepatitis. So you can never leave these individuals alone. You need to keep them on lifelong follow up. Hepatocellular carcinoma has one interesting feature about it, that there is a geographic variation. The same figures in East Asia are about 10 times worse than in Europe. So the risk of developing of HCC is zero point 0.2 per 100 person years in East Asia and zero point 0.02 in Europe. And we still don't know the answer why. There is a lot of molecular studies that went on it, but we don't have to bother. Again, chronic hepatitis, the chance in East Asia is much higher than in Europe. Development of cirrhosis is higher than in Europe. So, for some reason, the virus behaves more malignant in East Asia as compared to Europe. Based on what we have learned so far, the European Association for Study of Liver Diseases has now proposed new terminology, which is now becoming becoming accepted. So they've divided all patients with the Hep B markers, that is, into E antigen positive and E antigen negative. If you remember the previous slide, we talked about E antigen negative as a stage beyond inactive carriers, and E antigen positive, E antigen negative are both potentials for chronic hepatitis. So we have a chronic hepatitis here, we have a chronic hepatitis here. ALT is elevated irrespective of the E antigen. Here too, irrespective of the E antigen status, the moment the patient has been called as chronic hepatitis. That means our screening test in a person who is surface antigen positive is usually ALT, and we'll come to that because once that is elevated, you call them as chronic hepatitis. If that's normal, you call them as chronic infection. That means they're not cleared of the infection. They still have the infection, but they don't have hepatitis. So that shows us the role for ALT as we go ahead in the investigation and management of patients. Virus load again is important. Higher virus load is required for E antigen positive individuals than for E antigen negative individuals to develop chronic hepatitis. So a threshold of 2000 IU per mil for E antigen negative and 20,000 IU per mil for E antigen positive. That means these individuals need a higher virus load before they land up with elevated ALT. So let's come to the indications for treatment. We just talked on the previous slide about the importance of ALT. This is for individuals who have been diagnosed as having HPSAG positive. When we come to treatment, what is the next step that we do? Of course, we'll also do the virus load, we'll do the E antigen, but all these will follow, but are not essential for indication for treatment. The most important indication for treatment for us is the ALT. If the ALT is more than upper limit of normal and the virus load is more than 2000, you may want to do a liver biopsy to find out the stage of liver disease. If the ALT is more than twice upper limit of normal and the virus load is above 20,000, you don't need to do a biopsy. You treat these individuals. The third situation is where a person has cirrhosis and has detectable virus load. You don't have to quantify it. If he is detectable virus load, he needs treatment. So indication for treatment is where ALT is high, more than 2000 virus load, you need a biopsy. ALT is high, more than 20,000, you don't need a biopsy, you treat them straight. Virus load is high, irrespective, or virus load is detectable, irrespective of the ALT, and the patient clinically has cirrhosis, you treat the individual as Hep B. You don't need to have the ALT, you don't need a biopsy. If he's cirrhotic, compensated, or decompensated, and has a viral load detectable, no cutoff, then you need to treat the individual. So these are the three indications for treatment with or without a liver biopsy. On the other hand, if the ALT is normal, you don't need a biopsy, provided, of course, there are situations that are favorable. That means these individuals are less than 30 years of age, that is the immune tolerant or immune clearance stage. They are E antigen positive, and there is no evidence of liver disease in the family. That means if there is an individual in the family who's had hepatitis B related cirrhosis and another individual has hepatitis B, even though the ALT is normal, we'll need to consider that individual for treatment. So the threshold for treatment will drop the moment there is one more individual in the family who's developed liver disease thanks to hepatitis B. So our management algorithm, in a suspected patient with hepatitis B, you look at he's HPSAG positive or is he HPSAG negative and only anti-HBC positive, what we called occult infection earlier. So we divide them accordingly. Let's take the right side first. If he is occult infection, that means surface antigen negative but anti-HBC positive, there's no specialist follow-up required. But tell this individual that, or tell his doctor that he has the potential for B reactivation when he is immune suppressed. So, although this infection is by definition occult, if he is ever in a clinical state where his immunity is compromised, he will need antiviral prophylaxis. The other situation is what we call occult infection detected incidentally in individuals. We don't know what to do with them, although there's increasing thoughts now that we may have to consider them for treatment as well. So, surface antigen negative, anti-HBC positive, by definition, occult infection, no treatment required at that time, but there is a risk of reactivation. And in case of immune suppression, we will have to monitor or start them on treatment. The surface antigen positive individuals, if they have evidence of chronic liver disease, will go on treatment straight away. If they have chronic infection but no signs of chronic hepatitis, that means we have tested their ALT, we're looking at their virus load, we may have done a biopsy, and we find no evidence of chronic hepatitis, we keep monitoring them. Like I said earlier, even if these are inactive carriers, you cannot tell them that, look, you're cured. We need to monitor them lifelong because we need to consider the risk of hepatocellular carcinoma, the risk of HBV reactivation, the risk of transmission, and the risk of extrahepatic manifestations. And if any of these comes up in the clinical situation, they will also go for antiviral therapy. If they are absent, they will continue to be monitored lifelong. So, like I said earlier, Hep B individuals are patients for life. You cannot say that you're at low risk, you can go away. The risk is certainly low. It may be less than 5% overall, but it's still there. So you need to monitor them lifelong. Why am I bringing the life cycle of the virus in at this stage? Because we're not interested in knowing the details of this. That's for the molecular biologist and for the clinician interested in Hep B infection. I'm bringing it up here only to highlight one. That's the entry point for the virion. It's uncoated, gets into the nucleus, and there is a state of what we call covalently closed circular DNA, cccDNA. Why is this important? Once the cccDNA is incorporated into the nucleus of the host, no treatment gets rid of that. With the current treatment levels available to us, even if all other parameters are negative while on treatment, the cccDNA remains within the genome or the nucleus of the host. So even if the patient is well controlled on treatment with our endpoints of low or undetectable viral load and normal ALT and no evidence of chronic liver disease, the risk of hepatocellular carcinoma remains. So we need to remember this one word: cccDNA remains in the nucleus of the host, posing a risk for chronic complications like carcinoma, even when all other parameters have come under control. So, our goal of treatment now, of course, is to improve the quality of life and survival, prevent progression to cirrhosis or decompensation, HCC, and death with prolonged viral suppression. Undetectable virus is what we aim for now with our current therapies. With prolonged viral suppression, we can achieve these goals. But remember that the cccDNA remains in the nucleus, and this can lead to carcinoma even in individuals who are otherwise well controlled on therapy. So that's a sad story. Finally, let's come to the treatment. For many years, we had only the interferons. We had alpha 2A and alpha 2B, and these were antiviral treatments that targeted the host. And they acted in two ways. One is immune modulation. Like I said earlier, hepatitis B is also an immune mediated disease. The disease sets in when the body starts developing an immune reaction against the virus. It's not the virus that is cytotoxic, it's the body's immunity that creates a problem. So these drugs had immune modulatory effects as well as they targeted the antiviral proteins. But they unfortunately fell by the wayside because of their side effects. And at the time that they had a monopoly, the cost was high. Today it's become more affordable. The good news is that there is no resistance reported. The chances of clearing hepatitis B surface antigen is about chance of clearing is about 5 to 10%, which is very high in comparison to what we use today as antivirals. But because of the cost and the potential for side effects, unfortunately, these drugs have fallen by the wayside. Two other drugs, the nucleoside and nucleotide analogs, lamivudine and adifovir, were used earlier. Both these drugs have high resistance rates developing in the first few years of treatment. So because of the potential for high resistance, these drugs, lamivudine and adifovir, are now not favored medications. The unfortunate part is those who are LAM exposed in the past have a higher risk of developing resistance to entecavir later. So it's preferable now not to use these drugs at all in the treatment of hepatitis B. So our current favorites are two drugs, entecavir and tenofovir. Very good. All of them are recommended as first-line therapy. Both of them target the virus and inhibit the reverse transcriptase activity of the HPV polymerase. Very good resistance profile in that up to 6 years, the risk of resistance with entecavir is just 1%. And for tenofovir, no resistance has been documented so far. So this is probably the closest we can get to utopia. We have a third drug, TAF, which is a lower dose but has a higher or better safety profile in renal disease. So this drug was introduced mainly for use in renal disease patients who cannot be given entecavir for whatever reason or develop resistance to it, but needs tenofovir and cannot be given tenofovir because of the risk of renal damage. So our choice would be entecavir because it's renal safe, or TAF because that also is renal safe. But for practical purposes, in those who do not have a kidney problem, tenofovir is a more affordable drug with no resistance reported so far and is recommended as first-line treatment. Of course, the others still continue to be used as first-line. This is a relatively new entrant into the field, just for a few years now. So TAF has not taken off as well as entecavir and TDF have taken off. Like I mentioned earlier, even while on treatment, these individuals need lifelong monitoring. Every 6 months, you screen them for development of HCC, whether they are on treatment or off treatment. The risk is low in those who are on treatment and those who have low virus loads, but the risk is never zero. All their life, they continue to be screened for HCC, preferably every 6 months, but in those who have very low virus load or are asymptomatic, what we call the inactive carriers, every 12 months may be enough. While on treatment, we also check to see whether they are adherent to treatment so that they don't develop resistance. We keep monitoring the ALT and HPV DNA and the E antigen status because conversion from E antigen to E antibody is a preferred conversion, although that is not cure. So you don't stop treatment at that level. So practically, hepatitis B treatment today, there's no recommendation to stop the treatment. Some years ago, we used to think that stopping the treatment when the E antigen becomes E antibody positive and the DNA remains undetectable for 2 years, you could take a chance and stop the treatment. But now we realize in a majority of these, the infection will come back. Because remember, the CCC DNA remains in the liver. We also need to, of course, at baseline and every 12 months, monitor them for renal dysfunction, as I said earlier. Post-exposure prophylaxis, the people who don't need anything further, the no treatment group, is the ones who have been previously vaccinated and are known responders. Remember that this is a one-time vaccination, but we should confirm that they have developed the antibody. You just don't, unlike in community vaccination or in population vaccination, where we don't follow them up. If you are recommending vaccination for an individual, test to see that he has developed the antibody. Because if he's a known responder, irrespective of the exposure, he doesn't need any further step. On the other hand, you look at the source patient. The source patient, if he is HPSAG negative, known to be, you don't need to treat the exposed individual. If he's still undergoing vaccination, you complete the series. So if the source person is known B negative, no treatment. If the exposed individual is known anti-B positive, no treatment. In all the others, depending on the level of exposure, you would start them on vaccination with or without the hyperimmune globulin. So HBIG and vaccination, depending on the intensity of the exposure. No treatment only for those who have the antibody, the exposed individual having the antibody, and no treatment also if we know that the source is negative for the virus. Who should be screened? Obviously, all healthcare workers. This has now become a little redundant because we're now talking about universal immunization. But most of us adults did not have the privilege of universal immunization when we were young. So healthcare workers, all pregnant women, and all with chronic liver disease must be screened for this virus. Like I said, anybody due for immune suppressive therapy should have surface antigen, anti-HBC, and HBV DNA tested. Everybody undergoing hemodialysis or multiple blood product transfusions, and others who are at risk, institutionalized individuals, drug pushers, alcoholics, must all be screened for Hep B periodically. How do we prevent it? The most cost-effective strategy, of course, is universal vaccination. You need to have good donor screening methods available with sensitive tests. Like in our institution, for example, we use the NAT screening test, nucleic acid testing. The issue is about the surface antigen negative individuals who have occult positive, what to do with such donors. In good centers, these bloods will be discarded, but that's not yet a universal policy. Very important to create awareness campaigns in the community about the routes of transmission. Where do we stand in India? We started a universal program in 2002, scaled it up in 2011. We're hoping to double the rate of exposure by 2020 to close to 90%. Third dose coverage has reached 80% in 2015. We don't have the latest figures. So we are making good progress, although we are very late entrants globally into a universal immunization program. We are making progress, and we hope in the next 10 years we'll see the results of that. Finally, one word on hepatitis D. Hepatitis D, as you know, is an incomplete virus and infects only those who have surface antigen in circulation. So Hep D can occur only in those who have Hep B, or hepatitis delta can occur only those who have Hep B infection and circulating surface antigen, because this virus needs the coating of the surface antigen to be in circulation. So we don't need to screen this virus in individuals who don't have the hepatitis B virus. But even if we screen it, there's no recommendation for treatment. There used to be earlier thoughts about co-infections and super-infections, but currently it's not routine practice to test for hepatitis D. In passing, I must mention that India has a low prevalence rate for hepatitis D as well. With that, we move on to hepatitis C, and I hope we keeping good time. Hepatitis C, again, India is a low prevalence area. World over, 185 million chronically infected, 350,000 deaths. So if you compare this with hepatitis B, you'll realize that hepatitis C is one half in numbers as compared to hepatitis C. But that does not make it a less serious disease. Although the figures, like we talked about 2% for hepatitis B and we talk about 1% for hepatitis C, the number in India is still about 15 million people, 15 to 20 million people. And as we look at the outcome of hepatitis C, we realize that it's probably a more serious disease. So if you have a cohort of 100 people who have been exposed to the infection, if you remember our hepatitis B figures, we would say about 30 will progress to, or 5 will progress to chronicity, and 30% of those will progress to liver disease. Whereas compare that with the hepatitis C reports. 100 cohort, 80 will go on to chronic infection versus 5 for hepatitis B. Of the 80, 50 plus will have progressive disease. About 15 of them will develop cirrhosis. Whereas on the other side, we talked about less than 5%. And 4 of them will ultimately die of liver disease. So this disease has a much higher likelihood of chronic progression, irrespective of the age of acquisition. That one more difference from hepatitis B is that the time frame for development of these complications is twice as much as for hep B. So development of cirrhosis generally 20 years later, development of cancer 25 years later, end stage liver disease 25 years later. This creates a clinical problem for us because when patients are told that they acquired this infection 20 years ago, they'll wonder why had no symptoms for 20 years. This is the reason why, that it's a very slowly progressing virus. So a majority of the individuals we see today are the ones who received blood products in the 90s or the 80s, or the ones who were pregnant and were given blood at that time to build up their hemoglobin, or the ones who are undergoing hemodialysis and have chronic exposure. So most of these will come to us more than 20 years later with established liver disease, which is unfortunate. So it's very important for us to catch them early, especially now that we have good treatment available. A few words about the virus dynamics. Rapidly multiplying virus. A lot of quasi species because it doesn't have a proofreading function. So every day there is viral diversity being created. Every day there are quasi species being developed. And infection with one genotype does not prevent infection with the other genotypes. Why is that important? We've not been able to create a vaccine for this virus only for these reasons. The virus genotypes, India is almost unique, or Southeast Asia is almost unique in having the Geno 3 infection. We were fortunate in the days of interferon because Geno 3 had a better response to interferon. Unfortunately, this also meant that research in the West focused on Geno 1. And the drugs that we have as directly acting antivirals now are more effective for Geno 1 than for Geno 3. So while we had our honeymoon period in the interferon times, today Geno 3 is not the focus of our research as much as Geno 1 is. So we are at a slight disadvantage there. What are the tests we would do? An anti-HCV, there we talked about the surface antigen. Here we talk about the anti-HCV test. Why is the antibody important for us here? Because this is not a protective antibody. So the presence of the antibody does not mean protection. This is only an immune reaction. So if the individual is anti-HCV negative, for practical purposes, we'll presume that this individual does not have the infection. But that's not a universal statement. If the individual is immune compromised and cannot develop an antibody, like in renal failure individuals, hemodialysis individuals, or those on chemotherapy, just a negative anti-HCV is not enough. You must look for the HCV RNA as well. But for the population, the screening test is anti-HCV. If that's positive, then you don't want to have a false positive. So we will also check for the HCV RNA. And if the HCV RNA is also positive, this means that this individual has current infection. So screening test, anti-HCV. Exception to that in those who are immune suppressed because the antibody may not develop. Once it is positive, you confirm it to make sure that this is not a false positive, but it's a current infection by looking for HCV RNA as well. If the antibody is positive and HCV RNA is negative, it's a false positive test. And we may get that in certain situations. So we always need to do the anti-HCV and the HCV RNA if the risk of infection or if the suspicion of infection is high or the individual is immune compromised. Now, when it comes to treatment, because of the high risk of progression, unlike in Hep B, Here, the policy, the dictum is treat everyone. All patients with chronic infection, in fact, even with acute infection, should be treated. The only exceptions are those who have contraindications to treatment. That means individuals who are dying of some other disease, and that course will not change by treating hepatitis C or transplantation or directed therapy, then these individuals may not be treated. On the other hand, individuals with short life expectancy due to the liver disease itself, a specialist can decide that these patients will not benefit from treatment in the absence of transplantation option. Okay, so in other words, except for these rare exceptions, everyone else who's got hep C infection should be treated. We won't go into the life cycle of the hepatitis C because it's much more complicated here. The reason for bringing up this slide here is to talk about the targets for development of drugs. Like I said, all research in the last few decades have been predominantly focused on the genotype 1. So the drugs that we have now, all of them, irrespective of the category or the class, whether they are NS5A inhibitors or NS5B inhibitors, work better in genotype 1. But fortunately, they work in genotype 3 as well, which is what we have in India. So while we have protease inhibitors and NS5A and NS5B polymerase inhibitors available in plenty around the world, in India we have the first drug that came in was sofosbuvir, followed by daclitosvir and ledipasvir, and now we have velpatasvir as well. So Dacla, Ledi, Velpa, and Sof are the four drugs that we have available today in India as direct acting antiviral drugs. The treatment for us, if it is Geno 1, we have Ledi and Sof available. If it's Geno 3, we have Dacla and Sof available. Treatment now is only for 12 weeks, except in cirrhosis, where the treatment extends to 24 weeks. Now compare this with interferon, where the treatment was for 48 weeks. So here we have 12 weeks treatment or 24 for cirrhosis. Geno Velpatasvir is important because it is a pan-genotypic drug. So we don't even need to know the genotype when it comes to the use of Sof and Velpa. 12 weeks across the board, there's some data to say that this may not work as well in cirrhosis, but current recommendation is irrespective of geno and the stage of disease, you can use a combination of Sof and Velpa. So today in clinical practice in India, most doctors have changed to using Sof and Velpa, although Sof and Ledi and Sof and Dacla are also available here. We face a problem in the less than 5% who do not respond to 12 weeks of Sof and Velpa because we don't have a drug beyond that. So currently, our problem starts if we have resistance to these drugs and we don't know what to do beyond that, but that should be handled by the specialist. A word about cholestasis. You know that hepatitis B is a hepatocellular virus. It affects predominantly the hepatocyte, but 10% of those with hepatitis C may develop cholestatic features. And this drug, UDCA, is almost like a panacea. Every doctor uses UDCA for every liver disease. Its use is recommended only in PBC, and today there's some recommendations also coming up as a combination drug for fatty liver disease. But in days when we didn't have the direct acting antivirals, these drugs used to be used for normalizing SGOT, SGPT, and GGT levels. And there's some data from Japan that says that they were quite effective in bringing down these values. Now, these are surrogate values. They're not the same as curing the disease or getting rid of the virus. So UDCA has role as supportive therapy where you want to reduce inflammation or relieve, more importantly, relieve the cholestasis. Post-exposure management, I won't go into details, but you can study this slide a little later in more detail. If the source individual is HCV negative, then we don't have to do anything at all. If the source individual is unavailable or refuses treatment, refuses testing, then the exposed individual will have to be followed up. The difference here is we don't have a vaccine. So we're following up exposed individuals. If there's even a slight suspicion of risk in the source individuals, the exposed individual must be continued to be monitored. He continues to be monitored and may need treatment if he ever develops HCV antibody or HCV RNA. So for at least 6 months following exposure, we would monitor these individuals if we do not know the status of the source individual. I won't go into who should be screened because it overlaps those who have been screened for hepatitis B. Very important is these cutoff dates. The CDC talks about 1965, I mean, those born before 1965, and those who have been exposed to blood components before 1992. These dates will change for India because we made hepatitis C testing in blood banks mandatory only in 2001 and surface antigen testing in 1999. So any individual who's received a blood product or blood prior to these dates must ideally be screened even in the absence of test of symptoms. Very important for us on the national level. If you only put an ad in our newspapers and on television saying that if you've ever received a blood product, particularly prior to 2001, please test yourself, then it's very likely we'll pick up many more individuals who will benefit from treatment. Unfortunately, we don't have that kind of a campaign going on in India. Measures to avoid transmission because of shortage of time, but it's mainly hygiene precautions. And when it comes to sexual practices, there's no recommendation to change that, except to be faithful in the relationship and practice safe sex wherever possible. All the others is for illicit drugs and donation of blood and body organs. Prevention strategies are again common sense ones: screening, primary prevention; identification, counseling, and testing of persons at risk, secondary prevention; public education; and surveillance and research in the medical domain. As I talked about the problems with development of the vaccine, we'll not take this in more detail. This is again for the vaccine development industry. Finally, 2 or 3 slides on the elimination of hepatitis C. The WHO's Global Health Sector Strategy for Viral Hepatitis talks about elimination not as 100% reduction, but 90% reduction of new cases, 90% detection rate for all those who are infected, and 80% treatment for those who are eligible for treatment. If we achieve this, the WHO considers this as elimination to be achieved by the year 2030. So they have various strategies for Hep B and Hep C. I'll leave you with only one slide, which is more applicable to the West than to us. That if you're looking at between 2018 and 2030, where will the major cost of elimination come up? In the West, it comes up with Hep C treatment, Hep B treatment, and testing. Now, this may not be true for India because we are fortunate to have an industry that has made these drugs available to us at a much lower cost. But on a global scale, when the WHO looks at this as a problem, they are anticipating that a major part of the cost of eliminating hepatitis B and C lies with the cost of drug treatment and testing. The cost of infant vaccination over time will remain static. Harm reduction will remain static, but this is where we have the main reserve in our attempt to get rid of hepatitis B and C by the year 2030. So with that, I'll leave you to ask the questions that we have. Thank you so much for participating and listening.
Thanks a lot, Dr. Philip, for that educational and informative presentation. I would just like to give the viewers a reminder that they need to complete the assessment at the end of the session by clicking on next to receive the RCP points mandatory for the certification. Okay. With that, I'd like to invite our next speaker for the session now. Dr. Gaudas Chaudhary, I'd like to invite you to take over now, sir.
Uh, very good morning on a Sunday, and I think that all the colleagues who have joined me. I think Philip's lecture was very interesting and very comprehensive. I'll try to make mine a little lighter because I think otherwise you'll probably find it a bit too heavy. So let me see how we go about it. Uh, we have to share the slide. Can I get my slides here?
Yes, sir. I can see you've shared. Just need to be on slideshow mode now, sir.
Yeah, fine, fine. Is that okay?
Yes, sir. Wonderful. Please continue.
So, unlike hepatitis B, which Dr. Philip talked about, where the number of patients seems to be on the decline because of advances in vaccination, treatment, screening, and so on, uh, fatty liver disease has a completely opposite epidemiological profile. It's one disease which is steeply on the increase. And I think that as physicians, I'll be surprised if each one of you are not seeing a large number of patients with fatty liver disease. It's so common that you might actually think that, okay, it's really not worth worrying about. But I think you can actually make a living out of understanding fatty liver disease and managing it well, because it's bound to grow and there are bound to be more complications coming in. I shall discuss briefly about the diagnosis, the monitoring, and the treatment from a physician's perspective, not from a hepatologist perspective. Okay. So, in short, fatty liver disease means that the liver is stuffed with extra fat. More than 5% of the liver mass is made of fat. And when there is too much of fat, it looks greasy and yellow and buttery and big. And if you were to take a biopsy, this is what it looks like. You get those large spaces which are actually fat globules inside hepatocytes, and that's what gives you the diagnosis. As you can see in this screen, fatty liver disease is usually associated with quite a few comorbid conditions, the commonest being overweight or obesity, and then there are others like diabetes and so on and so forth. So we shall touch upon that a bit later. There are two types of fatty liver disease. So for a long time, when people didn't eat much, but some people had access to alcohol, I believe it was very common in Mumbai. It's probably still so, and in certain parts of the country. Um, Alcohol consumption in a fairly regular way in reasonably high doses is one of the, it used to be actually one of the commonest causes for fatty liver disease. So chronic excessive alcohol consumption, and that produces fatty liver disease, fibrosis, and then leads on to cirrhosis and so on and so forth. The story about non-alcoholic fatty liver disease is interesting, and I thought that I must share it with you because physicians would be interested. You know, it was somewhere in the early 80s that a very famous pathologist was given slides to look at, and he looked at it, and they had fat in the liver, typical fatty liver disease with inflammation. And he said that these are alcoholic liver disease. And then when they unmasked the demographic background of these patients, they were all women in the United States. And by the way, the pathologist was Hans Popper, very famous. So they went and asked these ladies if they had been drinking. And most of them, in those days, you know, ladies didn't drink as much as they seem to do today. So they denied consuming even a drop of alcohol. And it came as a big surprise because their liver looked like what one would expect from good amount of excess alcohol consumption, and yet they were not taking alcohol. So that then came the concept of non-alcoholic fatty liver disease, that you can actually have very similar findings, extra fat, inflammation in some people who don't take alcohol. Many of them, of course, were on high caloric diet, you know, a lot of uh, beef and red meat and cheese and butter. And you know, in the Western world, they use a cooking medium called lard, which is actually very rich in fat. So probably those were the reasons. But nevertheless, this concept came that you can have very similar histological changes even when you don't consume alcohol. So to touch a little bit about alcohol, you know, it is dose related, duration related. And there have been umpteen number of conferences, discussions the world over, where people have tried to argue and discuss as to what is the safe dose of alcohol and what is an unsafe dose of alcohol. And let me put it in a nutshell, people have still not reached a consensus. So every book that you read, and if you read these books from 1980 down to 2020, you will find the amount and the duration changing, each one author claiming to be a pioneer in his area till the next one comes along. And the reason is, we published a paper long time back that it's not really only the alcohol, but how the body metabolizes alcohol that seems to matter. And there are few enzymes, typically called the alcohol dehydrogenase enzymes. And apparently, genetic perturbations in these enzymes, there are different types of polymorphisms. They seem to decide why 20% of people who take extra alcohol develop fatty liver disease or liver injury, whereas quite a few others don't. But that's another topic. Don't go away with the impression that I'm encouraging all of you to consume alcohol with the belief that you're in the safe 80%. Now, alcohol is not dangerous only to the liver. There are umpteen studies which have shown that it is harmful to the body and to life. And remember that many deaths, in fact, a large number of deaths due to alcohol is not due to liver disease alone. It's actually due to unnatural deaths, suicides, homicides, road accidents, and so on and so forth. And the morbidity is also terrible in terms of the poverty, the dysfunctional families, and effects on children, and so on. So there is a simple questionnaire which I'm sure all of you use in your day-to-day practice. When do you know that alcohol is becoming a problem? So if you ask these questions, that have you ever felt the need to cut down on your alcohol? Have relatives, friends, or your family, have they expressed annoyance at your alcohol consumption? Do you sometimes feel very guilty that you are consuming it, although you still go on doing it? And do you sometimes need an alcohol in the morning or in the afternoon? Otherwise, your hands tremble and you're feeling very uneasy, so you need an eye opener. If any of them are positive, it means that you have something called an alcohol associated disease. But the terminology have changed. So it was called alcoholic liver disease. From that, we made it into alcohol addiction. And now you have a term called AUD. So alcohol associated disease. So that is how things are at this point in time. It's called AUD. It's alcohol abuse, or whichever way you want to call it. So this is what happens when you keep consuming alcohol. You develop fatty liver disease, which is quite common actually. And fortunately, in a few of them, it progresses to a stage of either alcoholic hepatitis or alcoholic cirrhosis. And then once it's a cirrhotic liver, it becomes a little prone to developing liver cancer as well. And that is something which is very well known. So that's the reason why, if any of your neighbors have alcoholic livers, have got liver cirrhosis, the family finds it very embarrassing, because the first thing they'll come and tell you is that, but he has never touched alcohol. And you need to be equally reassuring that yes, there are many other reasons also for developing liver cirrhosis. So don't give them that moral burden or blame sense also. So alcoholic liver disease manifests as either fatty liver, alcoholic hepatitis, or alcoholic cirrhosis. The alcoholic hepatitis part is fortunately relatively small in numbers, but it's got a bad outcome. And this presents with a fairly short-term rise in bilirubin with a decompensation, and usually the mortality rates are pretty high. But today's talk is on fatty liver disease, so I'll just skip the other two and then I'll talk about other things. Remember that with alcoholic liver disease, or for that matter with the two conditions that Dr. Philip talked about, and when the liver gets involved, quite a few enzymes get elevated. One of them is the alanine aminotransferase, one of them is the aspartate aminotransferase, one of them is the gamma glutamyl transpeptidase or transferase. Remember that there are quite a few enzymes which get elevated, also the serum alkaline phosphatase. But it's a matter of MCQ questions that the only enzyme which is produced by hepatocytes only is the first one, the alanine aminotransferase. The others are also produced by hepatocytes, but in addition, they have other sources also. For example, the AST is liberated from the heart if a person has got a heart attack. It can be produced from skeletal muscles. Gamma glutamyl transpeptidase again has a whole lot of other sources, just as serum alkaline phosphatase, there are 5 isotypes, and one of them comes from the bone, one comes from the uterus, one from the intestine, and so on. So if the question is which is specific to the liver, it's ALT. So how do you make a person who's into alcohol stop his drinks? It's in fact very difficult. It's not so much into the domain of physicians alone, but physicians need to play a very supportive and encouraging role and be the kind of a person who will give them a sense of direction. But it requires a multi-faceted approach: social, family, counseling, psychiatrists, so on and so forth. And there are certain medications which are important. Thiamine is to be replaced, otherwise they often develop thiamine deficiency and beriberi, a lot of neurological problems. There are nowadays medicines which are used for insomnia, because as soon as a person stops drinking, he doesn't get sleep and his hand trembles and he goes into anxiety and depression and craving. So there are medicines for craving. He needs to be given adequate protein because the liver is starved of protein. And there are medications which are used to buffer that phase, like ursodeoxycholic acid or S-adenosylmethionine and others. Now, normally, the worrying factor or the inflection point in any liver disease, be it hepatitis B, C, or fatty liver or alcohol, is the development of fibrosis. And earlier on, the only method that we had to understand or to detect the onset of fibrosis was liver biopsy. But try it in your practice. You ask them to go and get a liver biopsy done. 9 out of 10 will flatly refuse and walk over to the next doctor. So now there has been a compelling reason to find out if we can detect fibrosis by other non-invasive methods. And here are quite a few methods. So there is a FIB-4 score, there is a ELF score, a transient elastography, and so on and so forth. So the list is long, and I don't think that you should worry too much about it. But in your day-to-day clinical practice, may I advise you that you either download one of the apps which give you liver scores, and there will be quite a few of them. So there will be a CTP or a child's Turcotte-Spook score. There will be one called a MELD score. There will be one for fibrosis called the FIB score, and so on and so forth. And it makes a lot of sense in the clinic to just feed in the values with which the person has come and, tell him, oh, look, I think your liver is heading for stiffness. The stiffness is high and fibrosis has set in. And the doctor and the patient will look up to you with a lot of admiration and say, oh my God, like an astrologer, how did you actually get to know? But that's the way you can actually do it. But what FIB-4 score uses is AST, ALT, platelets, and age. So remember that with the onset of fibrosis, the blood platelet count starts falling, and the AST level overshoots the ALT level. So if you understand that principle, it makes it easy, but don't try to calculate it. There is a square root and what all involved, but use one of those simple apps which you can get on the mobile nowadays. And then there are other tests like the fibro test, which is a more complicated blood test, a fibrometer, and a liver stiffness measurement using a fibroscan. This is the one which we prefer in a tertiary hospital, and this has now become a fairly easy, reproducible, semi-quantitative method. This is the scan that we have. Looks like an ultrasound machine with those probes there. And this is the probe. You put it in the intercostal space on the right side, and you have these shear waves go into the liver. It's completely non-invasive, so no poking of a needle. And you take 10 measurements and you see the slope. So all that it does is, the more stiff the liver, more is the difficulty in having these shear waves to keep traversing the liver. And then you come out with actually a calculation which the machine does for you, and this is what the score looks like. So here, if this value is more than 7, it means fibrosis has started. This is obviously a very healthy score, whosoever it is, probably a child or whatever who's never even smelt alcohol. And this is the part which tells you about the fat in the liver. And this is an interesting modern version of the scan called CAP, that is a controlled attenuation parameter, which also gives you the amount, semi-quantitative assessment of fat in the liver. We find this very useful. So now I go into what causes non-alcoholic fatty liver disease. So imagine people who don't take alcohol at all, and they'll come and touch their ears and say, "Oh, we are pure, holy people, and alcohol is out of question," and so on and so forth. And yet they have fatty liver. It comes as a shock. So the genesis of it is insulin resistance. And insulin resistance is sparked off by a very simple to understand phenomena, which, I'm not a brainy guy, so I look at it in a very simple way. Whenever there is excess intake of calories and it's not being able to be burnt adequately, that calorie gets stored in the body. And what method that you have to store it is actually to convert it into fat. So if you understand that, that's the basic principle. It's an issue of calorie imbalance. More calories coming in by whatever form. It doesn't have to be fat. It can be sugar, carbohydrates, fat. Of course, fat has 9 kilocalories per gram, but sugar is 4. But it again depends if you are actually going around having 5 to 6 cups of nice syrupy sweetened tea and a whole lot of potato chips. I mean, it's more than what the liver can handle. So obviously that's one of the sources. And that sparks of insulin resistance, And insulin resistance leads to accumulation of fat called steatosis, which gets deposited in the liver. And in many of them, there is some degree of oxidative stress, genetic predisposition. So this fat becomes toxic. So neutrophils come in, there is some degree of fight between the fat and the inflammatory cells, and then the Kupffer cells are activated, the mitochondria, so on and so forth. So there is some degree of hepatocyte adaptation, but many of them die by various methods like apoptosis and so on. But the stellate cells are the ones which get activated finally, the stellate cells, and they are the ones which lay down fibrous tissue. And that's the beginning of liver cirrhosis. Okay. So this is the way things normally happen. If you want to understand it, we'll come back to it. There's a huge amount of research going on here, because people who are affluent, by the way, to a large extent, I would say doctors, despite the fact that 175 Indian doctors have died in the COVID ward, you see pictures of doctors in strikes or anything, you'll find most of them are actually, they look overweight, whatever. The fact of the matter is that we probably do less exercise, and we are sitting in our clinic most of the time, and whatever we eat, we are not burning enough. Now, why should it matter to you? So it should matter to you because earlier on, people used to say, extra fat in the liver on an ultrasound, that's very common, don't bother, it's almost like a normal thing, you can pass it off. But longitudinal studies have shown that both your 5-year and 10-year survival for people with NASH or non-alcoholic fatty liver is distinctly less than those who don't have fat in the liver. Of course, those who take alcohol and have alcoholic fatty liver, it's obviously even less. But compared to those who are lean and without fat, people with extra fat, even with non-alcoholic fatty liver disease, have shorter life expectancy. And that itself should make you worry. I mean, after all, what do you do as a good physician? You say that, look, if your blood pressure is on the upper side and if your cholesterol and lipids are high, you are at a higher risk of having a heart attack and dying. And the same applies here. And it's just a question of your awareness. And if you see the last part in this slide highlighted in red, interestingly, there is a heart liver connection. And one of the major causes of early deaths in patients with non-alcoholic fatty liver disease is due to cardiovascular disease. Liver cirrhosis, certainly in 20% of patients, but 20% is not so much. The majority of the patients who die, which actually gives that whole group a shorter life expectancy, is actually due to cardiovascular disease. So that's what's called the liver heart connection. And there was a very interesting study which showed that if you look at all the syndromes which you normally know, the metabolic syndrome, age, systolic BP, cholesterol, and NAFLD, the one which has got the highest odds ratio and the p-value, lowest p-value in being able to predict a bad cardiovascular outcome is the presence of fat in the liver. So it's actually far more accurate than metabolic syndrome. And as physicians, you will immediately understand why, because metabolic syndrome has got 4 or 5 parts to it, and all of them don't come together. So when you see one or two and you're waiting to look, I'll call it metabolic syndrome, when the third comes, it's often quite a bit. The damage has already started. So extra fat in the liver is a very good single time marker for a bad cardiovascular outcome in the days to come or years to come. Now, how do you manage fatty liver disease? There are many steps. So I told you that insulin resistance is one of the methods. So there are steps to try and see how to improve insulin sensitivity. The usual type 2 diabetic story. The next step I showed you is that after that, when fat gets deposited and something happens, inflammation starts. So there is something called oxidative stress. So you could try to block that second step using antioxidants. And then when that doesn't work enough, and there is a kind of a phenomena that has already been triggered, it's a cascading phenomena that goes on, inflammation, NF-kappa B activation, inflammatory cytokines, then you can try a whole lot of either hepatotropic agents or new molecules. I'll just give you a glimpse of some of them towards the end of my talk. But obviously, there are several steps involved in the development and progression of this disease. So people are working at different steps to try and see if you can stop or reverse some of them. Now, these are some of the common causes for non-alcoholic fatty liver disease. So if you get people with very high triglycerides, especially this is a phenomenon in India. In the Western world, it's mainly cholesterol. In India, it's often triglycerides, hypertriglyceridemia. Often occurs in even vegetarians, surprisingly. Hypothyroidism, there's certain drugs like amiodarone, steroids, uncontrolled diabetes or poorly controlled diabetes, hepatitis C, Dr. Philip mentioned. And one of the most important is actually being overweight, because being overweight means that there is more calories in your body than what you have been able to burn to keep yourself healthy. So I'll just give you a glimpse about how to try and reverse this process. So if you think that the frequency of non-alcoholic fatty liver disease in the community where you live, let me tell you the Indian data, it's about 30% of adults have that, 30%. So it's a little, I would say, funny to be able to prescribe medicines, expensive ones, to 30% of the adult population. And since it's a lifestyle disorder, one needs to actually focus on lifestyle. And there's been quite a bit of research going on, and as a good physician, you can play a role. So I'll touch exercise first. If you do exercise, don't ask me aerobic or anaerobic. Well, the answer is actually both. It's very interesting. I'll come to those. Exercise actually promotes GLUT4 protein, and it upregulates insulin receptor substrates. Okay. And we did a small little study when I was in Lucknow, and it was very interesting. We got people, about 60 of them, to do regular exercise under supervision, trained by professional physical instructors, and their maximal heart rate, it went up. It went to 60 to 70% of their maximal heart rate. That was the heart rate that we tried to achieve, with some degree of calorie restricted diet. And this was done way back, 2004 or something. And we could show that people who complied, their liver enzymes actually came tumbling down, whereas quite a few lazy people, they wouldn't do it, but we still rang them up and found out, and got their blood test done. So you find that their liver enzymes remained where they were, whereas this is the ones who followed exercise and diet. And as a subsequent part of the study, which got published in 2012 or 13 by my group, we also did paired liver biopsies in patients, some of whom had a lot of fat in the liver, but who followed this regime for about a year. Many of them lost about 8 to 12 kilograms of weight. And when we did the paired liver biopsy, paired means, a repeat liver biopsy from the same person, we could demonstrate that the fat had completely disappeared. Okay. And of course, the HOMA scores had also tumbled down. And this was the study that we had published, that lifestyle modification improves insulin resistance and liver histology in patients with non-alcoholic fatty liver disease. Now, these studies don't become very popular because there are no sponsors for it. So the large pharmaceutical houses would not sponsor lifestyle studies so much. So they would much rather work on a drug. But I think as good physicians, you need to be more aware of these issues. One of the new things which has really come up, and as good physicians, I would urge you to look at a study. It's a review article which came out in the New England Journal of Medicine as recently as the 26th of December 2019. That's just last year. On a new phenomena called intermittent fasting. So, there are a whole lot of diets. Many of them are fat diets. If you do a Google search, you will find that there are about 90 such diets, and 29 are already in vogue. So you have the keto diet, the GM3 diet, the Mediterranean diet, and what have you. But intermittent fasting is something different. Intermittent fasting is not about modifying the diet. It's about modifying the timing. And there are two types. It's called the 16-8 and a 5-2. There's also an AD, alternate day. But what it envisages is that you have long periods of calorie restriction. Very typically, in a way, done for a month during the holy month of Ramadan by Muslims, So they would eat their morning breakfast or cereal in the morning at about 3:30, and then have their next meal at about 7 in the evening. But that's of course for a period of a month or so, but it doesn't have to be that drastic. It can make it milder. So 8 hours of eating in a day and 16 hours of fasting. So these are the different types. You have a small window of eating, and the rest of the time you don't eat. And so I'll tell you why it works and why it is different from other diets. So this interesting review article showed that it reverses a whole lot of conditions, including type 2 diabetes, metabolic syndrome, the blood pressure settles, the weight starts falling in place, the lipids come down, the fatty liver really improves. And they've shown that your aging factors, so there are parameters to understand that, how the body is aging, and also your cancer risk. So there are certain types of mutations which keep occurring in the body, and life expectancy. So all these seem to be benefited. And this concept actually came from a study, not one, several of them, done in 5 parts of the world called blue zones. Have you heard of blue zones? Blue zones are basically 5 parts of the world where people live very long and become centenarians. And they found that what is so special about them that they tend to live so long and live healthily. And they found that they have a particular way of eating and living. The Japanese one is called ikigai, but this has now come into the domain of modern science. So lest you go back and say that, look, Dr. Chaudhary was only talking philosophy, I must give you some facts and figures from scientific journals. This is a study done on changes in body weight and body composition at week 4 and week 12 in patients undertaking intermittent fasting. So remember that this is not just a social media Facebook diet, okay? This is actually now very much within the realms of science. And you see the negative bit is the drop. So the maximum drop is seen with this orange bars. It's called ADF. ADF means alternate day fasting. That is, you take your normal food on a Monday, on Tuesday you consume 500 kilocalories, so it's a partial fast. So that's how it goes on every alternate day. That's a little too drastic, and if doctors started doing it, your patients will immediately spot it that on alternate days your mood is bad and you look tired. So I mean, it's a bit practically difficult. But the one which I want you to focus on is this one, okay? And this actually tells you that a milder form of intermittent fasting gives you a fairly good dip in your body weight and your liver fat mass. And to my mind, for people who are slightly on the overweight side and have extra calories and they are not willing to do exercise, intermittent fasting can be fantastic. In fact, a whole lot of doctors are, by the way, also into it. After a talk which I delivered in one of the national conferences, I was impressed to see one very eminent doctor from our community, gastroenterology. He got up and said that he has been following it for the past 9 months and he had lost 8 kilos and he is feeling more fit than ever. But patients will ask you for some medications. I mean, that's the expectation. And you also have that pad in front of you with a pen in hand with the RX on top. So when you feel that there is a compulsion to write something, well, one of the medicines which has been most widely prescribed has been this salt called ursodeoxycholic acid. It's a bile acid, and it's present in the normal body to the tune of 7% of bile acids, but not the commonest bile acid. But it's one of those healthy, friendly bile acids. And how it came to be used was the fact that polar bears who stay in the Arctics, for example, so they binge on a food which is basically seals, the animal called seals. And seals are absolutely laden with fat. So I believe if a human being, say from India, goes and has a meal of seal meat, he can actually die of hypervitaminosis A and D and an extra amount of fat that he can't handle. But polar bears don't. So people found out that their bile has got 50% of it is ursodeoxycholic acid, which probably helps them to manage fat much better. So that's how the concept came. And now, of course, there are, so this has been in the market for the last about more than 70 years, ever since I was a undergraduate from that time onwards. And it's been approved for quite a few conditions, particularly PBC, that's primary biliary cirrhosis, but it also forms one of the commonest prescriptions for fatty liver disease. The fact that it doesn't have any very strong scientific basis is another issue, because now there are better contenders that are coming, but it's a very safe medicine. The other indication where it's really useful is, of course, cholestasis of pregnancy. And another medicine which has also been in vogue for the last 40 to 50 years is S-adenosyl methionine. It's a it's a methyl donor, and it has got several roles in the body. Uh, Interestingly, there have been at least three Nobel Prizes associated with adenosyl methionine or methionine metabolism, but these were mainly in the 50s and 60s. But nevertheless, this is another fairly safe product which is in the market and often used for treatment of fatty liver disease. These have not been so specific, however, and that's the reason why there is a volley of research going on in different parts of the world, different labs, huge amount of billions of dollars being poured into research, and this is what people are trying to do. So there are drugs being developed to improve insulin sensitivity. Okay, so look at the number of drugs. Heading the list is pioglitazone. You must be knowing about it. It's an anti-diabetic. The only problem is that 40% of people who take pioglitazone also put on weight, and many of them are overweight to start with. Then you have got those liraglutide and semaglutides and so on and so forth, and there are quite a few. So you can go through this kind of a list, but this is where it's working, or at least attempting to work. Then you have got targets related to lipotoxicity and oxidative stress. And here you have got quite a few, including they're called the PPAR. And the PPAR agonists, there are quite a few of them, including your phenofibrate, which you use for bringing down triglyceride. And PPAR alpha gamma agonist is called saroglitazar, which has been approved for diabetic dyslipidemia and now for fatty liver disease. And now you have got the FXR agonists, which has come into the market, but at this point it's still not approved. But vitamin E, vitamin E has been a kind of an approved treatment for quite a while. The fact that it doesn't work too well is another matter, but it's been in use and it has got proven efficacy even in liver biopsy done studies. And then you have got a whole lot of drugs which are targeting other things like inflammation and immune activation, the targets related to cell death and apoptosis. This is a very interesting thing. You must have heard about this group of enzymes called caspases. These are the enzymes that regulate programmed cell death or apoptosis. So it was thought that if you try to prevent apoptosis, the liver will remain healthy because cells won't die so frequently. And somehow the first study that came in, I think just a couple of months ago, failed to show a clinical benefit. And it was reminding me of the story in the Bible. Philip will be able to give us the name. There was a person in the Old Testament who asked God for immortality, and he was granted that. I believe in Hindu mythology also you have that. And they realized that if you have immortality, you actually stop being productive and actually become quite a pain. So often people think that death is also not a bad idea, so that the new cells can come and it can regenerate the liver. So this is just for your interest. Remember that apoptosis is a method, and caspase inhibitors have been in use. And then you have targets related to fibrogenesis and collagen turnover, quite a few studies on this front. So this is, I don't want you to remember these, but as physicians, I just want you to understand that how medical scientists are looking at trying to identify new targets to be able to treat fatty liver disease. But as physicians, this is what I want you to remember. The problem is of excess intake of calories and very reduced burning of calories, and it is a lifestyle problem. So no matter what people tell you that it's genetic and blah 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 blah, remember that the gene pool in the community has remained the same for the last 200 to 400 years. So why should NAFLD become so common suddenly now? The genes couldn't have mutated. Okay, so the problem is primarily with lifestyle, and therefore in order to guide your patients to live longer, and for physicians it's probably in your commercial interest also that they live longer. For what reasons I'm telling you, it makes good sense to give them sound advice as to how to live healthy lives. Thank you very much for your patient hearing. I'll be happy to take questions.
Thanks a lot, sir, for enlightening us about that topic, sir. That was a really informative talk. So we have a lot of questions that have been coming in. So I just asked the question, sir. Either of you can take, depending on who wants to answer it. So the first question is coming from West Bengal, sir. It is from Dr. Pradeep Kumar Das from Hooghly, West Bengal. He's asking, after an infection with hepatitis B virus, how long does it stay in the blood, and how will we conclude him or her to be HB negative?
So should I take that question?
Obviously.
Thanks, God. That was kind of
Oh,
you.
by the way, what was that biblical figure, by the way?
I'll have to go back and read the Bible
I think it starts with M. Malthus
with
or something.
M.
Yeah.
Okay.
Well, anyway,
Mhm.
sorry. It
All
was a
right. Yeah.
long time ago that I read the Old Testament. So go ahead.
Okay. So the question was, after infection with Hep B virus, how long can it stay in the blood, and how will we conclude that he or her is B negative? After an exposure, of course, what we're looking at is what is the risk of transmission when a person is exposed to an infection. And there, Hep B is reputed to be 100 times more infective than HIV. So you just need a single prick, needle prick, to get infected with the hepatitis B virus. We talk so much about the HIV, but the HPV is much more infected. I mean, much more, yes, infective. Now, how long can it stay in the blood? I don't know about the circulation half time when we're talking about the blood, but blood is not an area where it multiplies. Multiplication occurs in the liver. So, unless the virus has taken hold in the liver and has incorporated its genome into the hepatocyte genome, you don't get multiplication. This is common to all viruses. Now, how will we conclude that he or she is negative after an exposure? Of course, is the development of absence of HBV DNA and preferably the development of anti-HBs. So absence of HBsAg, absence of HBV DNA, and preferably presence of anti-HBs are the three tests that we would need to know before we say that this person is Hep B negative. After, of course, a confirmed exposure. We wouldn't do these tests in everybody.
Thank you for that answer, sir.
Should I take the next question also?
Yeah, before we move to the next question, I'd just like to
Yeah.
remind the viewers about the assessment. You'll need to mandatorily answer the assessment questions to receive your certificate and the RCP credits. Yes, sir, you can move to the next
Yeah,
question now.
I'll take the one just above that. I don't know where it's from, but it says, please
Okay.
summarize the test for acute Hep B and chronic in case of vaccination. So we're talking about two things. One is making a diagnosis of acute and chronic hepatitis B. We talked about it. The first and only screening test that we have is the HPSAG. There are situations where we have an isolated core, but we wouldn't do that as part of community screening. We do that when we're looking for occult hepatitis B or in individuals who are immune compromised. In the immune competent person, the screening test is HPSAG, the surface antigen. For vaccination, ideally, if you're looking at vaccinating only those who need the vaccine, you should test for B surface antigen and B surface antibody. And if only both these are negative, you need to vaccinate the individual. Now, this becomes impractical when we're talking about community vaccination. And I think that question comes later down. If you're planning a community vaccination, you don't need to screen, you can just vaccinate all of them. But for an individual, if he wants to know, should I be vaccinated or not, ideally you should do the surface antigen and the antibody. A third way out is to test for anti-HPC, but that doesn't give him the information about whether he has the antigen or the antibody. So the practical best way is to test for both surface antigen and antibody. Going down, there's one doubt, the routine blood transfusion HPSAG rapid test being done. Is it safe, or do we need to do anti-HPC also? I think I addressed this when we talked about it. The recommendation across the world is to test for HPSAG. There's no universal guideline that says that we should do anti-HPC also. That's still in the realm of research. Now, a caveat about testing for hepatitis B surface antigen is don't do rapid tests. Do the best test available, which today is nucleic acid testing, NAT. If you don't have that, you should go for the next best test available. But just a card test or a slide test is not enough. For a donor, you must have the best test available, which increases the cost of blood components, no doubt, which is why a blood component in a private hospital, top of the line, like Dr. Gaur Chaudhary's hospital or any others, the blood will be more expensive because they use the latest and the best test. So it is mandatory to test for hepatitis B and use the best test available, which currently is NAT. There is no uniform recommendation for looking for occult infections because we still don't know what to do with them. Guidelines are not uniform on that. The next question again, Cora, you'll have your fair share of time, don't worry.
I'm not
Can a
worried. I'm
Can a
enjoying it.
patient, oh, thank you, but correct me when I'm wrong. Can a patient infected with Hep B virus or Hep C virus be infected with COVID 19? Why not? We know very little about the COVID virus, the coronavirus, or the SARS-2 virus, like we call it. We know very little, but none of these has a cross reactivity. So, Hep B or Hep C does not, to our knowledge currently, give any cross protection against against the coronavirus. So in that case, how will we diagnose clinically? Clinically, you cannot make a diagnosis. You can only make a suspicion. So there are typical situations that the WHO keeps talking about and revising from time to time, the latest entrant being persistent hiccups. So it's not only respiratory symptoms, but GI symptoms as well, or liver involvement. There are situations today, of course, our threshold for suspecting COVID-19 infection is very low. But the only way to confirm it is to get a test done. So if there is a suspicion, test in the routine way. Hep B and Hep C, to our knowledge currently, does not increase the risk of the COVID infection. And there's no separate test available for those who are suspected to be COVID-19 in Hep B positive versus Hep B negative or the other way around. Can a person previously immunized with B vaccine be infected with Hep B virus? The answer to that is yes and no. The yes part is only in the research realm. You'll find one in a few thousands who has been vaccinated earlier and then has developed the infection. And I'll come back to that. So those are probably different genotypes or serotypes. We have a common genotype, that's the A, and then we have the the TWYNR subtypes. So whether there is cross benefit from these, we don't know. But practically, so that's the yes part of it. One in a few thousands may get infected, and the researchers will look after why he got infected. But for practical purposes, if a person has been successfully immunized with the B vaccine, he will not get infected. If he does get exposed, he will clear the virus. So he will not get clinical infection. All right. So a caveat again to that is it's not just the B vaccine, it's also testing after vaccination. So on an individual level, after vaccination, you must test for development of antibody. And that is when we say that this person is a responder or has been successfully immunized, not just immunized. Successfully immunized means documenting the development of anti-HBs antibody. Now here there's a difference about what titers should be considered as protective. Across the Atlantic, there are two groups that say 10 and 100. But to the basic scientist, it does not matter what the titer is. The moment the person develops antibody, you know he is capable of mounting what is called an anamnestic reaction. That means although his titer is low, if he has a second exposure, the titer will go up. So in true science, all we need is to document that he's developed his antibody and then he's protected against future infections. Is there any Hep C vaccine? The answer is no. It's been in the research realm for many years now, but as of now, we have nothing on the horizon as well.
Philip, can I just come in for half a minute?
Speaks to that.
Yeah, I think what you mentioned was absolutely right. I just want the doctors to understand. There are two types of vaccination. One is the what we call as a routine community vaccination programs, where because of cost issues, we don't normally recommend doing the antibody test. That's the antibody to hepatitis B surface antigen, because we presume that most of them would be positive. But remember that the positivity rate occurs in only 95%. So there are 5% who are non-responders. So when you get a person who comes and tells that I had a vaccine, but I still got the infection, there are actually two possibilities. One is that he did not test himself before he got the vaccine. So he might have actually harbored the virus even before he got the vaccine, which often happens in the community. You don't always test before vaccinating. And the other is that he could be in that 5%, where he did not really ensure that he got protected, because we don't recommend it routinely. But why I'm mentioning this is that because you people are doctors, so healthcare workers, because they are considered to be high risk professionals, just like family members of an index patient of hepatitis B, in these two groups, it's absolutely recommended that after your three vaccines, you must ensure that your protective antibody titers have come. So the rules vary a little bit depending on whether you apply it to yourself or to the community. So I thought I'll just clarify that point. You agree with that, Philip?
Absolutely. When have I last disagreed with you?
Uh,
But coming back to the point, yes, that point needed emphasis, because we do get patients who are saying, but I took my vaccination. How did I get the infection again? So these are the situations where that can happen. Test, vaccinate, retest. That's the principle if you want to have a successfully immunized individual. Very important to test the antibody after that, which unfortunately we cannot do in community vaccination only because of the cost issue. So next question is, how do we manage hepatitis C in pregnancy? The answer to that ideally is, I wish I knew, because international societies also differ in their opinion on this. Although the US FDA has classified these drugs as category B, that means we don't know about absolute safety, but when you need to, you can use it. There is difference between them as well. The European Association says use a combination of drugs and treat them. The CDC and the American AGA, American Gastroenterology Association, also says treat them, but the American College of Gastroenterology doesn't recommend treatment as yet. So if we feel that you should be treating these patients, we have to explain the risk to the patients, saying we don't have confirmatory data about the safety in pregnancy, but we feel that it's worth taking the risk for whatever the clinical situation is, and use one of the currently available drugs. The drug that we will not use is interferon and ribavirin, both of which have been proved to be unsafe in pregnancy. So the DAA, the directly acting antiviral drugs, can be used with limited knowledge of the risk involved. The next question is, an adult who has not taken his Hep B vaccine in childhood, which is very common among adults today, wants to take hepatitis B vaccine. Is it mandatory to examine his surface antigen before giving him the vaccine? That question is the one that Dr. Gaur Chaudhary addressed. If we vaccinate him without testing him, there's a small chance that he may already be positive, and then we'll say your vaccination worked. So the best way is test him for the antigen and the antibody before you vaccinate him. Remember that we do not recommend adult vaccination across the board. But if an individual comes and says, I want to be vaccinated, you don't need to refuse it. You can just ask him, test and see whether you need vaccination, vaccinate, and make sure that you have been successfully immunized by testing the antibody post-vaccine. So yes, by all means, go ahead. And the current schedule is 0, 1, and 2 months or 6 months. That is 0, first date, 1 month later, second dose, and the third dose, depending on the vaccine makers, is at 2 months or 6 months. That means we have a leeway between 2 and 6 months. Remember that the third dose is actually a booster dose. Conversion usually occurs with the first 2 doses. Is genotyping necessary before treatment on Hep C? If you're looking at velpatasvir, which is a pan-genotypic antiviral drug, you don't need to. But probably because of age and I'm a slow learner or a slow turner, I still test the genotype. The reason is, if one drug does not work, I'd rather have the information on genotyping before I started that treatment to see if I have an alternative with another drug. Currently in India, we don't have the option, but if a drug becomes available, it's better to know what the genotype was before. But there can be difference of opinion on that. A good many gastroenterologists today would use velpatasvir without genotyping. What is the possibility of surface antigen positive person to travel to other countries for work? Any guidelines? Yes, these are local guidelines. For a long, long time, all the Gulf countries would test for Hep B before they would employ someone. But many years ago, some of the UAE, Emirates, and I'm not sure about the rest of the other countries in the Gulf, has taken off this requirement. They don't ask for hepatitis B testing prior to giving them a work permit. But some countries still do. So you will have to go by the recommendations in those countries. In most Western countries, I don't think it's a contraindication to granting work visa to these individuals. Of course, they will need to be followed up, but you'll have to go by the local recommendations. The next question is, if stable clinically and results wise, you have, okay, if it's going to be a lifelong intermittent therapy, the titers keep increasing after a period of therapy free. Does it mean that it would be better to give continued treatment rather than subjecting patients to the agony of, say, twice yearly testing for alteration? Okay, so I understand this question as, do you want to take a chance about discontinuing the treatment? The answer is, today we don't. The old recommendations say that you can take a chance, but then you need to keep monitoring them. Now we know that as we monitor them, most of them will come back with the Hep B virus, because these antiviral drugs do not eradicate the virus from the liver in most cases. And there's no way we can test on that. We're looking at only circulating surface antigen. So if the antigen is cleared and the antibody develops, yes, he's cured. Any other compromise testing like anti-HBe or E antigen conversion or absence of DNA is a compromise. And today we would not compromise. We'd continue them rather than keep monitoring them for life. You want to take a break and take the fatty liver conditions first, Gaur, or do I finish my B and C?
Go ahead. I think there are quite a few B and C questions. If you get tired, I could
Okay.
handle all three.
Okay. B is pegylated interferon. Where does it work best? The answer to that is when the virus load is low and the ALT level is high. That's the time that pegylated interferon works best. That means the individual is mounting an immune response, and pegylated interferon is boosting that immune response. So low virus load, high ALT is the best time to give pegylated interferon. Unfortunately, we don't see this combination in clinical practice frequently. Um, Okay, I'll just go down quickly. How do we address anxious patients with B positive, with E antigen negative, and low B HPV DNA? That's where our skills as a physician come up. We have to allay their anxiety first and tell them, look, you got this infection. It's not the end of the world. You've got wonderful drugs. But if you don't fit into the criteria for starting treatment, we'll need to keep monitoring you. Treatment is safe. We have excellent drugs with close to 100% chance, 90-95% chance that we'll bring the virus under control. But the issue for us is only when do we need to start treatment? Because once we start treatment, it's going to be lifelong. So you have to allay their anxiety, put the facts between them, and take control of the situation. Take charge, take over responsibility, saying, here on, I will keep monitoring you. Um, Okay, what is the role of basal core promoter mutation, especially in E antigen negative chronic Hep B? I'm not sure that this question is appropriate to an audience like this. Maybe we would handle that in our gastroenterology circles. Basal core promoter mutation is a mutation in those who are surface antigen negative. We don't test for that routinely. We'll probably take that up in another circle. Is there any clinical difference between presentation of Hep B and Hep C? No. The answer is all acute viral hepatitis can present similarly. So you cannot, on clinical grounds, it will have to be circumstantial evidence to decide when you will test. But it's only testing that will tell us which virus is there. Is there any chance of vaccination in the coming time? I hope it happens in my lifetime, but I'd rather not go further into that. How to treat a pregnant mother to prevent vertical transmission of Hep B if the mother's virus load is or Hep B or Hep C. I'll take Hep C first. If the mother is Hep C positive, there's a 5% chance of transmission to the child. If the mother is HIV positive, also the risk goes up to 10%. So in such a situation, you would want to treat the mother for Hep C. You cannot terminate the pregnancy, but you would be wise to test prior to conception. If you haven't and you found it during pregnancy, if the mother is HIV positive, by all means treat. If not, also with a 5% risk of transmission, you would treat the person while during pregnancy to prevent that 5% chance of transmission. Breastfeeding, not a contraindication. As far as Hep B is concerned, if the virus load is more than 20,000, you would rather treat in the third trimester to bring it down so as to prevent perinatal transmission or peripartum transmission. You may decide to discontinue the treatment later after the child is delivered. after monitoring the mother 6 months into the postpartum period. So at pregnancy, if you're treating the mother for Hep B only to prevent transmission, then once pregnancy is over and done with, and 6 months later, you can review the situation to see whether this mother needs to continue treatment. If not, you can discontinue that. Which is the best drug for treatment of Hep B in case of diabetic nephropathy with proteinuria? Either TAF or entecavir. You wouldn't use TDF because that has side effects on the kidneys. Is there a C vaccination in countries with high prevalence? No, we don't have a C vaccination available at all. And I think the rest of it, Gore, is for you. Extrahepatic manifestations of Hep B and Hep C. I should have inserted a slide, but there are a lot of them. Maybe at this stage, you can just go on Google and check that out. There's quite a few of them, particularly in the field of the rheumatologist and the immunologist. What is the affected rate of fetus from Hep A and Hep C infected mother? Like I said, for Hep C, it is 5%. With co-infection with HIV, it is 10%. Effect of on the fetus with Hep A virus? No, there's no risk practically. Best therapy for Hep B in diabetic nephropathy, we just covered that. In case of co-infection, which one should be treated first? God, do you want to take this up? Hep B,
Which one?
Hep C co-infection, which one should be treated first? I thought you would give a more lucid answer.
Well, I think if both the two viruses are active, why not both together? Because now the
Yeah.
treatment is pretty simple actually, in the sense
Yes.
that I mean these are oral drugs. This dilemma used to come when we were using interferon, but even then
Interferon.
the peg interferon would work on both. Usually the Hep C would disappear faster, but the Hep B often, the recurrence rates were high because the total response rates were only 40%. But right now I think that that probably shouldn't matter much.
Shouldn't matter. That's true. In patients already with chronic Hep B infection, won't superadded infection with A or E produce elevated transaminases levels? So how to differentiate them from costly BDNA estimation? Of course, we're talking about cost neutral discussion where we have to spend, we have to spend. And DNA estimation is expensive, but we have to, we have to. Now, chronic hepatitis B surface antigen infection by itself does not increase the risk for superadded infections. If we are talking about chronic liver disease due to hepatitis B, then certainly A and E produce elevated risk, not elevated transaminases. In fact, they may have low transaminases as compared to those who have a healthy liver. That means Hep A may give rise to acute Hep A, give rise to transaminases in the thousands. But in the presence of cirrhosis, the value may be restricted to hundreds or even less. So you'll have elevated transaminases that are lower in those who have pre-existing liver disease. But that is only for pre-existing liver disease. The presence of just the infection with hepatitis B does not change the clinical picture of A or E. But as a corollary to that question, if a person has liver disease due to Hep B, he should be tested for Hep A and vaccinated so that he never gets a super infection with that virus. Unfortunately, we don't have vaccines for Hep E. One patient admitted with mildly symptomatic COVID-19 who is having underlying chronic Hep B on tenofovir. Should we stop tenofovir therapy as we are planning antiviral therapy? We don't have a conclusive answer on that question, but I would suggest that we can continue both the drugs together. I don't know of any interference with the COVID-19. I don't know if Professor Chaudhary has an answer to that, but I don't know of any interference if we give both these drugs together.
Absolutely.
What should be the approach of starting biologics in patients with rheumatic disease found to be positive on screening for Hep B? If a person is going on biologics for any reason and has Hep B and DNA positive, we should be ideally treating him with the antivirals as long as he is on the biologics. This is more so in patients who go for steroids and on biologics. But if you want to be safe, then yes, you should be treating him while he is on biologics. Can Hep B be taken as a comorbidity in COVID infection? Yes, it is a comorbidity, but I don't know whether it will increase the risk of either of these infections if the other is present. Recommendation for interferon therapy, we talked about the ideal patient earlier. monitoring and specific treatment for fibrosis. Unfortunately, we don't have specific treatment. I think that question is more relevant to fatty liver, so I'll leave it to Professor Chaudhary. Are we still using PEG interferon plus ribavirin for Hep C? The answer is no, we are not. The DAAs have completely replaced interferon for Hep C. There are still pockets of use for interferon for Hep B in the ideal candidate, but for Hep C, no. We are now almost complete, not almost, we are completely changing over to the directly acting antivirals. At what intervals do we need to do fibroscan in case of, oh, that's for Gore. Okay, I think Gore, I'm done with my question. Maybe you can take up the rest of them and fill up the gaps that I left in Hep B and Hep C.
You can sip your cup of tea if they give you, but I'll take a
Thank
few
you.
and get you back. Quite a few questions. So let me
Quite
see
a few
where
of
do
them, yeah.
start?
Start scrolling from the top.
Yeah. So I think, how do you manage NAFLD in type 2 diabetes? Is that where I start? Is that okay?
Yes, sir.
Um,
Yeah. Okay, I'll start with that. Okay.
yeah, I think that's the first question, Gore. Yes, it is.
Yeah, it is. So one small thing that I want all of you physicians to understand, when we talk about hepatitis C, we are talking about cure rates of 98%. When you talk about fatty liver disease, then there are cure rates are not that high. I mean, they're only about 30%. And the reason is that it's intimately a lifestyle related disease, and there are multiple other factors that go with it. Okay, the comorbidities and so on. So if you look at clinical trials, the best effectivity for any drugs for fatty liver disease is about 30 to 40%. You can never achieve a 98% for a metabolic disorder. Okay. So I think that part you need to understand. So this question is, how do you manage NAFLD in type 2 diabetes? The question, I'll throw it back to the person who asked. How do you manage type 2 diabetes? So if it's a person who has got a faulty lifestyle or a eating habit and is overweight, I would say that focus more on the diet and on the exercise part of it, and go a little less sharply on the medical part of it. But otherwise, whatever you do, like, metformin is a good medicine to start with. It's supposed to be a good medicine for insulin resistance also. Surprisingly, there have been studies done with metformin in fatty liver disease. It hasn't shown too much of reversal of the fatty liver part of it, but nevertheless, it's a very useful drug for the treatment of type 2 diabetes with fatty liver disease. The drugs which have been actually found to be pretty good, these are anti-diabetic drugs which are also useful for fatty liver. And I believe nowadays quite a few hepatologists are sitting with diabetologists, because our areas seem to overlap quite a bit. And there have been studies on empagliflozin and the group of medicines which come with that. Then you have the gliptins, and then you have, of course, metformin. And so these have been used. I mentioned to you liraglutide also, very useful. But you must understand that you don't jump up to a very expensive medicine just for a simple common problem which can be managed otherwise. But if your question is that, are there specific anti-diabetic drugs which have shown the fat from the to move out from the liver, yes, there are quite a few studies which are now available. But I still think that, if your focus is quite a bit on other things and the diabetes part is associated, it makes more sense. But there are specific medicines. Liraglutide, for example, I hope you know, it brings down your weight, it improves your diabetes, and it's a very good medicine for fatty liver. But it produces, it slows gastric emptying. So a lot of people are quite badly dyspeptic. It's expensive, and so there are so many other issues with it. It's an injectable preparation and all that. So you have to balance the two. Somebody has asked me why vitamin E is not recommended in fatty liver with diabetes. Actually, it's not contraindicated. You can use vitamin E. I think the controversy that came with vitamin E, let me explain this to you. There was yet another question further down. Somebody said that, can you use it without a liver biopsy? The answer is absolutely yes. Remember, that the first trial where it was done, it is called the Pivens trial, Pivens, Pivens trial. So in any registration trial, you need to be very thorough and prove your point very well. So that's why liver biopsy was mandated when you had to prove the point. So all patients recruited had to have a liver biopsy, and then at the end of about a year or two, you had to have a liver biopsy. Once the point was made, then for day-to-day practice, you don't always need a liver biopsy. Okay. And the two major side effects which happened, vitamin E is otherwise a very safe medicine. All of you know that. I think for many reasons, the doctor gives vitamin E. In males, if it has been given for a longish period of time, usually more than about 6 to 8 years, there has been an association found with the development of prostate cancer, a slightly higher incidence of prostate cancer. And there was once a little scare about intracranial hemorrhage also, which people are at this point not very sure of. So otherwise, it's a safe drug. The question is about effectivity and whether to use it for a very long time, maybe 10 years of double dose vitamin E in a male who's say around 45 or 50, who is also prone to developing fatty liver disease. Obviously, prostate cancer risk will go up as his age progresses. That would normally happen. But whether vitamin E might enhance the risk by a small percentage is the issue. Okay. Number two, what is the can NFLD be cured by maintaining regular exercise, calorie restriction, and weight restriction? Very good question. So, there was a beautiful study done from Australia, in fact, even our study, and there were a few from China, which showed that you can actually cure fatty liver disease with these measures. You can cure it. But when I say cure, what do you actually mean? It means the fat disappears when you are very rigid with your diet, lifestyle, and what have you. The problem thereafter occurs is that are you able to maintain that rigid lifestyle for the rest of your life? Which does not happen. And in fact, there was this study which I am quoting from Australia, which showed that about 75 to 80% of people relapse. And they relapse because they actually give up that lifestyle. It's sometimes very hard to maintain it. But when there is a target in front of you, you can achieve that cure. Since you will think that I'm talking through my hat, let me explain. When the indication is very emergent, like for example, you have got only one donor for a liver transplant of a relative, and you know that donor is otherwise okay, except that he has got fatty liver, and the surgical team says that look, it would not be advisable to take this liver, so we will wait for 2 to 3 months and see if we can get the liver fat out. Believe it or not, Philip will bear me out. If he goes on a semi-starvation diet with a lot of exercise and all that, within a month, the fat actually really plummets down. And then he undergoes a liver transplant, donates his liver. But thereafter, 6 months to a year down, you find that he is putting on weight again. Now, that is the genetic, the predisposition that he has from his lifestyle. So that's where the problem is. Next, please. That somebody has asked a very interesting question. Currently, we are using hand sanitizers in quite a huge amount. Will it affect liver after absorbing through the skin? It's a good question. In fact, in one of my talks, I was asked that since alcohol kills the coronavirus, is it time for us to have a good amount of alcohol in the evenings to keep corona at bay, because it would kill the virus? Now, what you need to understand is that the alcohol rub that we use has got about 60 to 70% of alcohol content, I mean percentage. It's quite concentrated. Now, first the oral part of it. For the blood levels to reach that high and for those levels to reach to the lung, you'll have to drink a huge amount of alcohol, which will kill you otherwise. So that's the reason why the antiviral effect of drinking alcohol doesn't seem to work. When it comes to the hand, there are now quite a few conditions which have been described. In fact, I would urge you to just go to Google image and search for it. Alcohol dries up the skin, and it makes the skin shriveled up, and it looks very odd. There are a lot of people who have got a lot of coarse hands with this thing. And these pictures are frightening actually. So overdoing the alcohol hand rub is also an issue. And therefore, initially people, when they were too much panicky, they were using much higher concentrations of alcohol, and they've actually tapered it down a little bit now to make it more compatible with your hands and tissues. So those are two questions. So I don't think that the alcohol gets absorbed through the palms and soles to affect the body in any way. That's it doesn't happen. What is the level of triglycerides in the blood which you would take as a cutoff for initiation of treatment? Very good question. Let me ask a counter question to all of you. I gave you an example during my talk. I said that there are many vegetarians who have very high triglycerides, and it's very typical in India. In fact, I've been practicing in Uttar Pradesh, and I find a whole lot of them, a particular community, they are strict vegetarians, and their triglycerides are very high. So, do you know nutritionally what is the source of triglycerides? It's not the fat, it's carbohydrates. And this has been one of the important findings, because primarily people are consuming a lot of cereals and sugars, and that gets converted to triglycerides in people who are genetically prone. Now, the question is, if you want to keep it down and you know that it's a long lifetime issue, I would focus a little bit more on nutritional correction and try to see if we can keep it down. The normal cutoffs are 150 is what is mentioned in most of the lab reports. So I wouldn't jump to treat any person without a disease if his triglycerides are say 170 or so. But yes, if they're in the range of about 400, 500, and he has got fatty liver disease and he has recently had say some issue with the heart, he definitely needs treatment. The question thereafter comes is what to use by way of treatment. We all know that fibrates are the ones, it's not the statins but the fibrates. But there are two or three main problems with fibrates, and some people don't tolerate it well. So you must keep that in mind when you initiate treatment with fibrates. Otherwise, it works very well and gets the triglycerides down. I hope you know what I'm talking about. So huge amount of body ache, spasm of the muscles, and primarily muscular, and there are several other issues. So you must be aware of it. The other way of looking at it is that fibrates are basically PPAR alpha agonists. So now if you think that the person is a diabetic or has fatty liver disease, you have got a molecule which is an alpha gamma agonist, which also helps to bring the triglycerides down. That's in the market. But you have to choose one which the patient can actually take, and depending on the comorbidities or the risk that is associated with the triglycerides, right? What else is there? Is there any more? If blood lipid parameters are normal, is there any role of statins in fatty liver disease? Very, very good question. There have been studies done with statins in patients with fatty liver disease, and they found that giving statins when the cholesterol or lipid levels were normal was not very useful. Statins. Okay. In fact, they also used statins once upon a time when I used to do my research on gallstones to try and see whether it can dissolve gallstones. It didn't work. Okay. But the fact of the matter is that, again, there are so many factors playing. The second last slide which I showed you, that it may not be statin that works, but one of the medicines which was shown in an earlier trial to work for fatty liver when lipids were normal was in fact a fibrate. But today you don't use a fibrate when the levels are normal, because you have got other products to use. Okay. So I wouldn't use a statin unless you think that the statin is indicated otherwise as a risk reduction for future for coronary artery disease or something like that. What is the role of basal code promoter? This I think was for Philip. And then, is there any clinical difference between hepatitis B and C? What is the best drug for treatment of hepatitis B in a case of diabetic nephropathy with proteinuria? For you, Philip. But if you ask me, I would say that probably this, since there is nephropathy, and if you think that the person has a long life ahead of him, My choice would actually be TAF, tenofovir alfenamide. But would you agree with that, Philip?
Yes, absolutely. I did take this question earlier.
Okay.
Entecavir is safe,
Yeah.
and TAF. Yeah, but you wouldn't use TDF, the
Yeah.
regular tenofovir that we have in the market.
Quite right. And of all the things which Philip mentioned, the only point that I had to add was that uh, tenofovir is considered a class C drug, in pregnancy. So class C is not the best in a way, but what it has in its side is that it's got a huge amount of experience to back it up, because tenofovir was one of the ingredients of the HIV regime which was used in sub-Saharan Africa during the HIV outbreaks, and it was found to be fairly safe for the children, in the sense whatever I mean, there wasn't any increased association with any side effects. So from that point, even if it is it's class C, it's considered safe because the trial data has shown that it's been quite okay. So the question is to Dr. Chaudhary: is there a guideline recommendation on intermittent fasting, on where it should be avoided, regulated below a certain specific body weight BMI? Very good question. Very good question. So I'll tell you what. Uh, First, clinical trials come, then you get actually multicentric trials, then you get meta-analysis, and then after a while, then wise people like Dr. Philip and all, they get together and they review all the literature, and then they come out with guidelines, often sponsored by a sponsor, over a dinner meeting. So I think intermittent fasting hasn't come to that level, because obviously in intermittent fasting the dinner won't be there. So so to answer you, there are certain contraindications for intermittent fasting. If you have a person with a brittle diabetes who is on a very tight diabetic control with anti-diabetic medicines and or insulin, you have to be extremely cautious. Number two, what is the advantage of intermittent fasting? See, this that part I forgot to tell you, so I think all of you should know. During periods of prolonged fast, say 16 hours, what happens is that the body starts looking and attacking fat in the body for its energy, rather than looking at carbohydrates and protein. Okay, so normally the brain and the body uses carbohydrates and protein for energy, but when you have a long fast and it's not getting carbohydrates and protein, then it actually turns to the fat, and that's the reason why you're able to actually burn fat by intermittent fasting. And the longer the periods of fasting, more is the fat burning. Okay, so the question that you have asked is a very good question. If you have a lean person who doesn't have too much of fat in the body, he may not be the best candidate to indulge in intermittent fasting, because there won't be too much fat for him to burn, and he might get into other complications. So these are few points that you must keep in mind. And there is a diet which has actually been adapted from the intermittent fasting diet. It's called the Ramadan diet or the Ramzan diet. The only issue that I have is that during that holy month, they also, I mean, they restrict water for you. And I think that, sometimes if it falls in the summer months, I do not yet know what is the scientific rationale for restricting water, in the sense that, whether hydration has a role to play. So I would say you should be able to drink lots of water. Can we safely use vitamin E in patients with NAFLD who haven't had a liver biopsy? I've answered that question. Any role metformin in non-diabetic patients with fatty liver with respect to insulin resistance? Very good question. You know why I'm saying very good question? The commonest indication today that I see people munching metformin in non-diabetic conditions is young girls with polycystic kidney disease. It's unfortunate. I mean, in the sense that there have been few studies which have actually brought out the fact that this is linked to insulin resistance. So now people are actually prescribing metformin left and right for non-diabetics. This has come under a bit of a cloud, a question. But the fact of the matter is, if you were to use it, it's fine. But for fatty liver, I don't think metformin is a good drug. There are other medicines to use. Okay. Then following a Hep E infection, how many days it takes for the LFT to come to normal? Will issuing a med certificate depend on this? Depends. I face this problem very frequently. The general principle is that if you get a hepatitis A or a E in a child or a teenager, the LFT usually reverts to normal within 4 weeks. If it happens in an elderly person, I have sometimes seen it taking quite a bit of time. And surprisingly, I've had quite a few women who have had hepatitis E and their LFTs have remained abnormal for beyond 6 months or so, causing concern. And that usually leads to search for other causes. And if you actually get a autoantibody test, you will often find an anti-nuclear antibody in 1 in 40 titer. And that often raises this issue that is it a autoimmune liver disease? I don't think so. In the sense that, many of them, if I have followed them up over a period of within a year, they do settle down. And certainly for autoimmune hepatitis, I wouldn't accept a value of 1 in 40 to think in terms of doing a liver biopsy. But that's my take. But Philip, you can give your comments.
So I'll just put in an additional word here. The decision to give a certificate does not depend on the Hep E infection, but it depends on how quickly the liver has recovered. So for practical purposes, especially when time is a constraint and somebody cannot get leave, of course, the ideal time would be to wait till the transaminases come to normal. We don't have to wait for the bilirubin to come to normal, but the transaminases. But practically, if a person is pressed to getting back to work, I would issue a certificate once it shows a downward trend and has crossed the threshold of 100 ALT. Okay, but this is only in extreme situations. If a person can take rest till he comes to normal, that's the ideal situation. So you'll have to balance these two. We don't have to check for the Hep E status. Once the liver has recovered, he's fit to go back to, to work or to school. But to extend what Dr. Chaudhary had mentioned, hepatitis E has always been taken as an acute infection. And we had initial reports saying that in the immune compromised, hepatitis E can turn to be a chronic infection as well. Now we know that in immune competent individuals also, hepatitis E sometimes can become a chronic infection. So ultimately, you're looking at issuing the certificate based on the ALT, not on the recovery rates for hepatitis E antibody or HEV RNA.
And to compound the problem, the issue is that the HEV RNA is not an easy test to do. I mean, when I've tried using it in our routine laboratories, most labs are not offering that test, and so you need special labs to do it. It assumes importance in immune compromised people. I'm sure that even some people might have that virus lingering for a long time, but the antibody test, if you repeat it and it keeps coming positive, it doesn't matter. I mean, in the sense, obviously, it's going to be there for about 2 to 4 years, so that won't help you. That's a problem. So I think it's good to go by the point that Philip mentioned, that go by the ALT. And since I mentioned fibroscan, I must also tell one small thing to all of you. If you get a person with an acute liver injury or an acute hepatitis, never get a liver fibroscan done. You know what? I have been treated almost like a god because somebody had acute hepatitis and had a liver fibroscan done by another doctor, and the value was 70. So
That's
he
not the
was
only reason, Kaur.
no. So
That's
I'm
not the
telling
only reason.
yeah, no, I'll tell you what. So that obviously makes the person write a diagnosis of liver cirrhosis. And this fellow was so depressed, he was almost writing his will. And I just told him that, look, hold on for a while. After about a month or so, get the fibroscan repeated. And then it fell down to about 15. And after another 2 months, it actually fell down to 7.5. So he, tore off his will. So I just thought that I must tell you these stories. Whenever there is acute liver swelling, the fibroscan will be high because what it measures is not fibrosis but stiffness.
Yeah.
I think Philip will actually tell you more
Yes.
about it if time permitted, that it was basically discovered to find how stiff the cheese was in France when they were exporting cheese. So it's not for fibrosis but for stiffness. Very interesting. What is the next thing? Can we use statins in an
Statins.
NFLD with fibroscan proven patient whose transaminases are more than 3 times upper limit of? So, if you're practicing in India, and I think that your transaminases are high, but your cholesterol is low, or I would say your total cholesterol, LDL cholesterol, they're all normal, I wouldn't use a statin. Statin also sometimes pushes up the liver enzymes, you know that. So if at all I had to use something, I would probably use one of the other medications that I talked about. If I'm really hard pressed and if I find the triglycerides are a bit on the upper side, actually this fibrates have been used for treatment of fatty liver disease, but that was almost 15 years ago. They have a much safer liver profile than statins. But today I've got so many other good medicines, I wouldn't actually use it unless they're high. Most preferred DAA regime for Indian patients. Philip, your question, but if you want me to take it, I can do that.
Yeah, I thought I answered that already, that we have three combinations available now with us. Sofosbuvir with velpatasvir, ledipasvir, and daclitasphere. So there's nothing to choose between them except that ledipasvir and daclitasphere are used for specific genotypes, and velpatasvir is a pan genotype. So most gastroenterologists have changed over to velpatasvir only because it's a pan genotype. But response rates, if used appropriately, are the same.
So there are two questions relating to fibroscan, and I think they are very important. One is from Girija Shankarji, and the other one is from Shamal Chatterjee. There are two issues when you are doing a fib4. So you asked for fibroscan, but I'll just take you to the other side also. Remember that the fib4 uses it's based quite a lot on not just the liver enzymes but the platelet count. And believe me, at least in the kind of practice that I have, when a person comes in with different CBC reports, I find quite a wide variation in the platelet counts. Does it happen in Hinduja also?
Yes, it does.
Okay.
It does. And then, of course, there's this problem about manual and lab. I mean,
Yeah.
manual and machine.
So be very careful before you stick your neck out and scare the patient and say that he has got advanced fibrosis. I would be a little wary. When it comes to the fibroscan, again, the issue is there is something called inter-observer variation. And it's so common that once the person goes to another lab, and most of them are being done by technicians now, and he gets a value of 12, which means that there is some degree of F3 fibrosis, and he goes then to another one after 2 months, and he finds that he has been taking, say, homeopathy for a while, and there the value comes to 9. He usually looks upon it as a significant improvement. What you need to understand is that there is also a degree of what is called as an inter-observer variation, which you need to standardize. So if you have multiple technicians doing it in one particular center, you have to calibrate it and see that the reports are consistent, number one. Number two, it varies to a large extent also on the weight of the person and the probe that you are using. So if you have a person who's a little on the obese side and you don't have that obese probe, and you are using the other probe, you can actually get fallacious results. So they need to be consistent over a period of time, and you have to correlate it with other findings. In terms of, by the way, being much more objective in your assessment, what is emerging is actually MR elastography and fat content measurement, which actually the inter-observer variation tends to come down. But at this point, it's still in the research phase, so I wouldn't recommend that you keep doing it as a part of your practice. But very good question. What is the best treatment for NAFLD except exercise? Well, if you are, so there are different types of NAFLD. So, there is the obese NAFLD, the diabetic NAFLD, the lazy NAFLD, I would say
Lean.
the lean NAFLD
Lean.
and the cotton NAFLD and so on and so forth. So I would say that, if you are really not going to do exercise, and if you are a little on the plus side, to my mind, from what the studies I have done, and from at least about 10 to 12 doctors who have now been on intermittent fasting, ever since that report came in, I would say intermittent fasting is very useful if you want to just modify your diet a little bit. But calorie restriction would be important. And to some extent, I really don't know how you can go through life without doing a reasonable degree of exercise. Fair enough, some people are, say, wheelchair bound or whatever, and they just can't do it. Then I think the focus shifts more to the diet part of it. Okay. And maybe with some degree of medications that can be used. So that would be my take on it. Any
Yes, a
other?
diet really can bring it down by 5%, but a diet and exercise can take it up to 10%.
Absolutely.
Yeah. And we need at least 7% control.
Absolutely.
Yes, doctors, thank you so much for your expert opinions. I think that was about it for the questions part of it today. So before we end, sir, let's like to remind the viewers that to receive their certifications, they need to click on the button next after the session is done and answer the MCQs, then generate their certificates for the RCP credits. So before we leave, sir, we just like one take home messages from both of you, sir. I'd invite Dr. Gordas to go first for your take home message, sir.
So I think on for hepatitis B and C, the focus is on diagnosis and antiviral treatment and vaccination. It's clear. So the human being is more of a passive fellow because this is the technology which you are using. For fatty liver disease, it's the other way around. You have to understand that the human being or the patient is in the center as the main active participant. And therefore, since medicines will only play a supportive role, much depends on you as a physician to motivate him for lifestyle, diet, and exercise changes. Fair enough, good medicines are also coming, but I think there is no end to the length of prescription that we have, not just for fatty liver, but the comorbidities that it brings. So here I think the role of a physician is going back to the Osler days where you actually need to reinvent your skills as a physician rather than only as a prescriber. That's it from me.
Yes, Dr. Philip,
Okay,
we
the
would
only
like to
additional
have your
point,
take
yeah,
home message. Yeah.
yeah, only additional point to whatever wise words that Dr. Gaur Chaudhary always gives us is about the management of Hep B and Hep C. If we go by Western guidelines where they say that you need not test for these viruses in other situations, we should see that it's a different context altogether. The cost of testing and treatment in the West is far, far higher than in India. So we should keep our thresholds low. One, because it's affordable testing and cost and treatment. Number two, if you find an incidental Hep C, you cure them for life with the currently available treatments. And number C, the risk of chronicity and complications is much high if these individuals are not detected and left alone. So understand that when we look at the cost benefit analysis in India, it's much more favorable than in the West. So we should reduce our threshold for testing. It doesn't matter if you have a few negatives that along the way where you gain nothing from testing. But especially when our exposure levels, our screening levels in the blood bank are so low, and our general public hygiene, I'm talking about parental exposure, is not as strong as in the West, I think we should reduce our threshold and be more liberal in testing and take up more patients for treatment if we have to make a difference. In the utopia where we have universal vaccination and a protected population for Hep B, these values may change. After 2030, when Hep C is under control, the statement may change. But till then, the current generation should be liberal in testing.
Thank you, doctors. Thank you for your expert opinion, and thanks a lot for taking time on a Sunday morning for this session. We'd like to remind the viewers once again they can click on the next button post the end of this session and answer the 10 questions and generate their certificates for the RCP credits. Please make sure you answer the questions correctly because it is mandatory for certification. With this, I'd like to just thank everyone and we'll bring this session to a close. Thanks a lot, doctors.
Thank you. Thank you, Hitesh.
Thank you, Philip.